pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you all. Please be seated. I'd like to welcome everyone back. Hopefully everybody had a good Thanksgiving. We do have two new members that I'd like to mention. Jason Winslow, if you want to stick your hand up there, welcome, Jason. And Doug Isaacs, also over there. Welcome to SEMAC. If we could have a roll call, Val.
Okay, good morning, right? It's still morning time. Okay, Dr. Bart.
Present.
Dr. Berkowitz. With a nameplate, too. Dr. Barry, Sharice Barry. Dr. Tiffany Bombard. Dr. Arthur Cooper. Here. Dr. Jeremy Cushman.
Cushman here.
Dr. Michael Daly.
Daly here.
Dr. John DeTralia. Dr. Don Doynow.
Here.
Dr. Stephen Gomez. Dr. Douglas Isaacs.
Here.
Dr. David Kugler. Here. Dr. Joshua Lynch.
Here.
That's Joshua, not Joseph.
Thanks, Val.
Dr. David Markowitz. Dr. Matthew Maynard. Dr. Lewis Marshall.
Present.
Dr. Pam Murphy. Dr. Dan Olson.
Olson here.
Dr. Matthew Talbot.
Here.
Dr. Brian Walters.
Walters here.
Dr. Robert Wislinski. And Dr. Jason Winslow.
Present.
Non-voting members, Orrin Barzilay. Aidan O'Connor. Mark Philippi.
Mark Philippi, present.
Marianne Portoro.
Marion Portoro, present.
Dr. Jeffrey Raybridge.
Raybridge, present.
Michael McAvoy.
McAvoy's here.
Steve Kroll.
Steve Kroll, present.
And John Washkow. Hold on.
Do we have a quorum?
We have quorum.
Excellent. Okay, if I could have approval of the 4/12/22 minutes. Anybody would like to make that motion? And I should mention, please state your name for the transcribers when you do talk.
Dr. Chair, I think that would be September 22nd.
Olson will second.
Oh, yes, that'd be fine. Okay, all in favor? Anybody against? Any abstentions? No. Okay, minutes are approved. Okay, Ryan, Bureau Staff report, if you would.
All right. Good afternoon, everyone. So, for the Bureau report, in the operations world, Marrow continues with their full-service inspections and getting through most of Suffolk County, I believe, and working towards Nassau County and up into the Hudson Valley. So if you have any questions on that, please reach out to either Rich Robinson or one of your district chiefs. We are also going through the hiring process for 2 new district chiefs for the Marrow office. And the renewal paperwork will be coming out shortly, so keep in mind if you need renewal paperwork, that will be coming out. In the western region, they had a small snowstorm recently, and just a couple inches. And I just want to give a shout out to both the Western Bureau of EMS team, as well as I think Greg Gill is here, who is the Erie County Commissioner for Public Safety and Deputy Commissioner, and just a phenomenal job. When you talk about what's the point of collaboration and everything else? This past storm really just showed it. We almost had a deployment on that one as well. I know many of you received, and we got questions related to the state mobilization plan and deployments. We were literally probably within a couple hours of needing to deploy additional ambulances there. Thank God things went in a really good direction. But it was also a good test of, again, the system that we've improved. And unfortunately, through COVID, have become a little bit too good at in that process. So thank you again to the Western team from Bureau and everybody who helped make that happen out there. In investigations, that continues, and normal timelines are continuing on that one. On the administration front, we continue to execute the program agency contracts, and we have regular discussions with those program agencies in order to see what documents are missing and what we need to in order to execute them. As of right now, we have 8 executed program agency contracts. On the REMSCO side, we have 9 executed. So again, if you're not sure if your program agency or your REMSCO or your REMAC contract, which your REMAC is through the REMSCO, is completed, please work with your program agency to see what we can do to help complete that. But there is good process going on in that one. In education, we continue processing applications, and I think I heard John say that we had about 600 EMT courses so far this year, so excited to see that one. There are 22 core sponsors in New York State on the paramedic side, and I believe in short time, by the end of the year, hopefully we'll have 22 that have also gone through the accreditation process through national accreditation. So excited to see that one as a standard set in New York for all of our paramedic education. We're working with the Education and Training Committee related to some regional training plans, and I think Mike McAvoy is going to report out on that one a little bit later. We're working also with PSI on some feedback that we've gotten this week on testing availability, some things. I know people want to get back to a classroom-based test in some cases. That probably won't happen just based on technology and limitations. We've tried to get to it, but what we are going to try and move towards is group scheduling, to where a core sponsor can schedule their students, because the biggest complaint we get is, well, the student never scheduled their exam. Now, why you would take an entire EMT class and then get to the end and not take your exam, I'm not sure, but understanding, I guess, some do it, we're going to try and limit that and give them every best chance to become certified and get out into the field. We are working on some updates on the reciprocity process, although it is online, and Drew Chesney has been doing a phenomenal job on that one, so thank you on that side. In our data and informatics unit, it continues to grow and continues to take on more responsibilities under Peter Brody, and just excited to see that one. So we are doing an audit right now of all the PCRs that come in. And in some cases, we are noticing that some PCRs that are coming in electronically are either getting held up somewhere, or there's a gap, or there's a time lag, or so on and so forth. And in some of those cases, the agency isn't aware of it. And so, that's a little bit of a problem. So we understand if you're not aware of that problem, how would you fix it? So we are working on some solutions, hopefully going to work with the program agencies as well to, resolve that issue and take a look at, if there's anything that we can do. So far in New York State, we've received nearly 3.5 million to date for 2022 in PCRs, and so excited to see that one. We also, through our data and informatics, which does have a nice grant from OD2A, we continue with some projects with that, and partnering with them and the local health departments. We're working to get out to local health departments biospatial. So excited to see that one in 3 pilot counties. And then we continue to work on new documentation standard, which we know everybody is excited to get and read. So we're excited to get that out there to you. In the trauma world, we're working on regulatory reform on 405.5. If you've been following that one, it's some minor updates in the grand scheme of things, but the big update will be the book and the standards that they follow. There's a major change that's happening in 2023, and we're trying to get the regulations to align with that in the same time that the national standards do align with it. We're also continuing to see an increase in the number of applications for level 3 trauma centers. So we have 3 new level 3 trauma centers, and they're not necessarily downstate, which is nice to see that it's not in the most populated area for trauma centers, but actually starting to see some more in other areas, which we are excited to see. And that next STAC meeting is on January 24th. Those who want to participate or watch. EMS for Children is growing. Jacob DeMay, who actually was on our data and informatics team for a long time. He's sitting over there at the end. He's also our Drupal specialist. He has now accepted a role as a pediatric data specialist within our EMS for Children grant. So excited to have him there. And he'll be working on the hospital portion of the PEC program. So, the pre-hospital, and the hospital portion that's, going to be rolling out. The EMSC grant application has been submitted. Hopefully we'll hear back shortly. The EMSC EMS survey will be coming out in January, so for your agencies, please have them reply. And the EMSC meeting schedule is due to come out shortly. So vital signs, we were super excited. We had about 750 people at the end of the day. I will tell you, EMS providers in true fashion sign up last minute, and boy, did they in this year. About a month before, we had about 200 registrations, and we ended up with about 750 registrations. So thank you, for probably giving Val a slight heart attack in the process there. But it was a great success. We got a lot of great feedback, some phenomenal speakers. So thank you to everybody who participated, and in particular to doctors and the doctor panel and Dr. Daly and Maya and everyone who made some really great panel discussions happen. Next year, by the way, we are back in Syracuse, October 17th to 22nd. Mark your calendars now. The memorial. So our memorial will be in May, and we are working with them on the new memorial. However, at the way things are looking, there's a decent chance the new memorial will not be there in time. Supply chain and everything else, and making sure that we get the right thing for what we need and not just replace it with something that we think isn't perfect for the amount of meaning that it has. So hopefully I'll have an update for you back in February, or coming up in the February meeting. I'll have a better update. Council Ops, there's a list of all the dates. I think that was on the table. Correct me if I'm wrong, Val. Excellent. So all the dates for 2023 are up. Please mark your calendars now so that there's no conflicts. With OASIS, we have our mental health grant that continues. And Jenny, who should be in the back, where is she? Stand up for a second, Jenny. Jenny is with our mental health program and is traveling around the state to teach the class. And if okay with you, Mr. Chair, during new business, or if there's a few minutes, I would love for her to explain to the doctors a little bit about the program. It is free. She travels around the state. She is looking to go to more areas. We're looking to get into certain geographic areas that we haven't scheduled yet. So we'd love to, connect that with the physicians here and help make that partnership happen. So we're going to be coming back to you in a few minutes. From our side, I wanted to, and again, Mr. Chair, it's up to you if you'd like to do this now or a little bit later, but I would like Chief Major to talk a little bit about MOLST and what's happening with facilities. That is up to you if you want now or later.
Can we do it now?
No? Sure. Chief?
Good afternoon, everyone. From the MOLS side, we were really making significant progress with Dr. Dorsett, the MOLS team, and a significant number of people in here, Dr. Cushman and some others. What happened was the document, the MOLS form was in the final approval process. It was actually nearly approved by the department, and then additional feedback came in from OPWDD, their lawyers, their legal team. So it sort of set us back. And I don't have an actual timeline. We've been trying to push that forward to get that finalized and released. So the entire MOLS team, which has diligently worked, Mike McAvoy, you've been on this, you've experienced the delays in the other components, but we did do a session at Vital Signs, which was well attended. That's certainly on the Vital Signs Academy. There's a lot of information that is changing, including some of the training and education that will come once the form is actually approved. So there's actually a MOLS meeting going on right now, which I'm not attending. Unfortunately, the form is not approved, so it won't move forward there. Secondarily, we've had some training opportunities collaborating with the Adult Homes Division And that rolled out, basically it was a level setting opportunity. Regulations from the adult homes versus EMS regulations have some variances. Specifically some of the most things related to what expectations are from an EMS perspective in adult homes. We have another session which is based on feedback from the first adult homes interaction, which is available on Vital Signs Academy if anybody's interested in it. It was well attended, I think over 700 providers. It was ACF and EMS providers and leadership that attended that, but it is also available on Vital Signs Academy. December 13th, between 1 and 2 o'clock, there's a second session based on feedback from EMS as far as educating individuals about what types of facilities and the level of care that can be expected at those facilities that they respond to. There seemed to be some confusion related to that. Director, I don't think I have any further comments unless there's questions.
Any questions from anyone here? Anything else that you would like Chief Major to bring back to that MULS committee related to possibly questions of medical control or interactions that you may have with that form? All right. Thank you, Chief. Moving on from the regulation side, the education regulations have cleared through an internal regulatory process and committee that's to keep moving up. The operations ones are actually due to go to that same committee the week of December 19th. And then it will move to next steps. The EOs that are in place. So the only EO that is executive order that's in place right now is the staffing crisis EO. Continues in effect, and that was actually recently renewed. The Rural Health Task Force, there are 2 members that are left to be filled, but I hope to have a full list of those vetted members to everybody at this group, so they're aware of who's on the Rural Health Task Force at the February meeting. But I am excited to announce that Ann Smith has been placed as the chair of the Rural Health Task Force, so we think that's an excellent opportunity. Where is Ann? There she is. Congratulations, Ann, on that appointment. And just for situational awareness, that's actually an appointment through the governor's office by the governor that she is sitting in that seat. So congratulations again. And with that, the last thing, we have 2 or 3 policy statements that are going to be coming out next week. One is about oxygen tanks. We've been getting a lot of questions on oxygen tanks related to how to look at them and determine if they are compliant or not. There's an update on education. That's an update to the education policy statement that came out recently, just some minor updates that are going on in that one. And I believe there's one other one. So I think, yes, thank you, the IGEL protocol. So the IGEL protocol or process and how to apply and everything else at the request of the IGEL project, we did put it into a policy statement with supporting documents, who to call, who to contact, everything else that goes along with that one. And so that is, there. The last thing that I would update on, as we work on regulatory updates or regulatory reform, is blood. We are starting to look at blood now and the blood statutes that changed recently for air medical, or last year for air medical, that allows air medical to carry and store blood. Does have correlating regulations that need to come out, and so we're going to start on that process now. If there's anybody who has input, suggestions, or comments, we do welcome that as we go through that process. Thank you so much.
Thank you, Director Greenberg. Mike McAvoy. Yep, go ahead, Dan.
The one that looks like a person.
Hello, there we go. Dan Clayton from the Bureau. Just one correction on a date. State Trauma Advisory Committee is January 25th, and it will be held here at the Troy Hilton Garden Inn, not the 24th, for the record. Thank you.
Thanks, Dan. Education, Mike McAvoy. Dr. McAvoy.
Training and Ed met yesterday and kind of exceeded our hour that we were allocated. Couple of things from the staff report. Ryan mentioned 2202, which is instructor certification. Policy is going to be reissued with some tweaks to it. There's a link that will appear on the Bureau website shortly that has all the forms that people's little hearts could desire to fill out for everything that goes into the Drupal system. The AEMT exam has been reviewed by the Bureau. It turns out that there were no endotracheal intubation questions on that exam, so that's been cleared to proceed. There was a trial done on the new PSE that one of the training and ed committees has been working on for the EMT exam, and that was done at SUNY Cobleskill. There's another trial coming up in Suffolk, and that went pretty well, got some good feedback. The book itself, the draft of that, is still being revised and will be looked at over the course of the next month or so by the committee that's working on that. One thing that became evident when they tried this new practical skills exam was that this cannot roll out immediately and probably will not appear until 2024, primarily because of the complexity of the exam for the students and the preparation that's necessary for them to take an exam that, rather than focusing on exactly the skills that they provide, gives them a scenario, a comprehensive scenario, and that is a different type of test for the students and was very challenging for them and probably requires more preparation in the class and more education of the educators that will be working with administering the exam and teaching people how to take it. So you won't see that happening immediately, but we'll give you some feedback as the process develops. There was some discussion on course funding, and we're waiting at this point for responses from the Finance Committee. They have 44 course sponsors who have provided data on the actual costs of the courses. Once we get that information, we'll play around with the numbers and see if there needs to be some revisions in the funding allocation. There was a discussion at the December meeting, and we continued that, on the idea of allowing all course sponsors, not just specialty course sponsors, to deliver certified instructor updates. And after a very lively discussion, it appeared as though the preference would be to keep that limited to just specialty course sponsors. We are, however, going to create a work group that's going to take a look at certified instructor update requirements and see whether the requirements that we currently have in place are reasonable, given some of the changes that have happened over the course of time with continuing at all levels, so to be continued. There was a discussion, as Ryan mentioned, on PSI testing, and so we received some good feedback from some of the regions on issues with PSI. That contract is going out for RFP, and some of the requests that were made from the regions will be considered in the revision. There's a thing called Zendesk, which generates tickets that are issues that happen with the PSI testing, and the Bureau is going to provide some data from that Zendesk application to the Training and Ed Committee so that we can kind of have a better finger on the pulse of what actually are issues that are arising with the PSI testing. The group scheduling has been trialed in a couple large agencies and will probably get rolled out to the rest of the state at some point in the future once the quirks are ironed out from that, and that will allow a course sponsor to group schedule an entire class for their practical exams. There is an email address, which I think we've mentioned here before, which if people are having problems with scheduling their state exam with PSI, it is much more effective to email the Bureau than it is to try to wrangle with PSI over the phone. And that address is ems.testingissues@health.ny.gov. So if people have issues, that is a much better route to go with questions or concerns. And my experience with that has been that most people get an answer within about a half a day when they send a query in on that email address. So kudos to the Bureau for keeping a close eye on that. We asked for some volunteers from the Training and Ed Committee, and I'll throw that out to everyone in the room here, to work with the EMSC folks on developing some education for the new pediatric behavioral protocols. So if there's anyone who has an interest in working with the MSC on that. They're looking for some folks to help them develop the education there. Couple other things that came up. Data, the Bureau reported to us that for the past year, there were 12,000 folks enrolled in courses across the state. 60 of those were CFR classes that graduated 1,000 new CFRs. There were 600 EMTs that graduated 9,000 new EMTs, and 30 AEMT courses that produced 300 AEMTs, and 66 paramedic courses that produced 800 paramedics. Some of those were refreshers, and those numbers don't actually include CME research, so that's a large number of folks that are coming through the classes. One item that we have, well, let me just talk about this last thing, and I'll bring the item up for SEMAC. We are in the process of attempting to develop a training plan template to use so that the Bureau can approve courses, and we had another lively discussion about this. As you know, the geographic limitations on course sponsors were deemed to not be legitimate by the Division of Legal Affairs, which means that any course sponsor can just plop in and do a course anywhere in the state that they feel like it. That's causing some problems. One of the solutions that the Bureau undertook recently is any course app that gets filed goes to the regional program agency and to the SEMSCO of the place where the course is going to be delivered. So that keeps people a little bit more in the loop about what's happening in their regions. But to help the Bureau to actually approve courses, we are seeking to develop some sort of a training plan template where we would solicit the proposed or the necessary courses that need to be done in a region on a looking forward basis so that the Bureau can then use that as a methodology for approving courses. I pulled out one that we had been using for probably 15 years or so when I chaired the Finance Committee. It collects data retrospectively and then prospectively asks about classes, but it works very similar to the HERD system, if you're familiar with that, where people just make up numbers that they want to submit for courses. And when we actually looked at that, there were regions that were proposing to recertify 3 times the number of providers that actually live in the region, and other regions that put in data that was woefully insufficient. So the Training and Ed Committee is going to play around with trying to come up with some sort of standard template that we can use to predict what a region would need for classes and help the Bureau to approve those. The item that we wanted to bring to SEMAC has to do with a conversation that we had a couple meetings ago, and that had to do with providers' use of medical devices. And our recommendation is that SEMAC come up with a SEMAC advisory, basically describing how medical devices that are used at the local level would be approved. And our understanding is that is generally done by the agency medical director, but this issue continues to come up to Training and Ed, it continues to come up here at SEMAC, and it continues to come up at SEMSCO when some new whiz-bang product comes out and they come to us and say, could you endorse this, could you approve it, or the opposite of that is complaining about someone using a device that isn't actually approved. And this body never really has approved products, but we're passing this along to Dr. Doy now and the SEMAC colleagues for development of some sort of a statement so we can resolve that when they come up in the future. And unless there's any questions, that's the end of my report.
Thank you, Dr. McAvoy. Is there any discussion on that? Anybody have any questions? Anybody want to make a motion? At the moment, all I hear is crickets. Dr. McAvoy, did you want to make a motion?
Well, I would make a motion that SEMAC work with the Bureau to develop a SEMAC advisory on approval of medical devices for use by providers.
Is there a second to that? Who was that? Dr. Raybridge. Any discussion on that? Okay, everybody needs more caffeine. Dr. Olson.
Olson. Can we do that? Can we, as a body, approve a specific device? or
It wouldn't be a
devices?
specific device. If I understand what Dr. McAvoy has stated, it would be up to the medical director to approve a specific device. We don't, as a body,
Right.
endorse a specific
So I
device.
guess,
So I think from my understanding, what this would be is for this body to determine that they're not going to endorse or approve any specific device, but that they would clarify both to the region and as a body that the role of a specific device should be done by a medical director of the agency after the appropriate training and competency has been shown and rolled out.
Dr. Cooper?
Thank you, Dr. Doyne. I believe the statute does specifically speak to a CMAC approval of regulated medical devices. So I think some clarity as to how that should be interpreted should be included in the advisory. Thank you.
Thank you, Dr. Cooper. Dr. Raybridge?
Yeah, no, I was going to say something similar, in that we need some more detail on that and specify if it's going to be left to an agency medical director, the parameters around that, if there are any regulatory ones.
Dr. Doino?
Yes, go ahead.
Mark Philippi. I happen to have that section up, and we discussed that at exactly a little bit ago. As Dr. Cooper points out quite correctly, it is regulated medical devices. So as I think we all know, there are probably a fair number of non-regulated devices that are being marketed to us probably on a regular basis. So that's probably the more pressing matter at this point, is letting our physician colleagues who are at the agency level know what their expectations are.
Any more discussion on that? I would just also add, it needs to be within the scope of practice of that particular provider. Okay, we have a motion on the floor. If you would like to read it back for us again, Dr. McAvoy. And
Can I just, I'm sorry, there's one other point to that. I just want to get clarification. So you just send the standards for what the equipment list should be, or because any medical equipment that's selected would be FDA approved and so on. So I'm still not quite sure. Is there a training component to this? Because I think a lot of agencies sometimes lack training components to medical devices. Would be very helpful for all regions. Or so what is specifically? It's not clear to me what we're voting on.
Dr. McAvoy, if you would.
So it's really voting on developing a policy that would clarify all those questions. And I think the point of the policy is that really to say that training and ed, SEMAC, SEMSCO are not the ones responsible for what equipment and devices are used, that's the local medical director who's responsible. And probably also at the same time, which would be incorporated in the policy, responsible to know what those are that the agency uses and know that the people are trained to use them.
I mean, I think in some cases we look at it and we say, we don't approve stretchers. We don't turn and say, okay, Stryker, you're approved, Furno, you're approved, in those aspects. But they have to have a stretcher on board that's, going to be safe. So the other thing is and EMS for Children has done some work on this related to different equipment and safe transport of a pediatric patient. So they may be a reference for you to look at and how they approached it, because I think they also tried to stay sensitive to not endorse or not necessarily approve anything specific, but kind of that concept and then some resource guides that might be with it. So I'm sure Amy would be happy to help facilitate that as well.
So, Dr. McAvoy, we're going to vote on CMAC recommending that we put out a policy statement. Would you, by any chance, be able to put that policy statement together for the next meeting? And if so, then we'll vote that you will put that policy together.
Why, certainly.
All right, if we could just have a show of hands, is everyone in favor of? One more question, go ahead.
Yeah. So I was just reviewing section 3002-A of the Article 30, and it gives REMAC the authority to, well, I'll read it to you. Section 32-A, number 2. The committee shall develop and recommend that to the state council statewide minimum standards for, et cetera, and then it says medical equipment. Isn't it that use of regulated medical devices by emergency medical services personnel? It's page 15. So I think if the REMAC is supposed to have some say, or the SEMAC, about using regulated medical devices, is that's what we're talking about, use of regulated medical devices. So I do agree that there needs to be some agency training and education. But in our region, a best practice is we then notify the REMAC of this great new device that's being approved, and it allows other agencies to see it, share, and if they want to adopt it as well, they can. So I do think that before we just say it's only on an agency, do review Article 30.
I think that's a point of this working group, is to clarify kind of some of those points and what, positions and medical directors, this table, would want to see in that, both in interpretation and working with, Division of Legal Affairs within the Department of Health, as well as interpretation of these things. But, I think what the goal was is that not every single medical device or concept that comes up comes in front of this body, because from my understanding, and feel free for this body to say elsewise, they did not want to sit here and approve specific devices along the way. And as we get more, let me pause there. Has that changed?
No, I don't believe that has changed.
Okay, just checking. And since it hasn't changed, to have that framework of how we're going to handle that, including references like that, because it absolutely does. It does reference medical equipment things, both for the CMAC and the REMAC. So I think that this policy statement and guidance document would work to clarify and see what that role is and involve it. And like you said, point out things that might be, hey, report it to your REMAC so they can ask questions and get feedback and maybe do a study or whatever that might look like.
Yeah, that would be my recommendation, is to add the language into it that, although it doesn't need to be approved by the REMAC, that it should be shared with the local REMAC for also knowledge of neighboring agencies of this new possible device.
Okay, thank you, Dr. Winslow. Well, we do have a motion on the floor. Can we have a show of hands? All in favor of Dr. McAvoy and his group putting together a policy statement? Okay, anybody against? Any abstentions? Okay, that passes. Let's, Dr. McAvoy, are you done?
Yes.
Okay, moving along. Next would be Med Standards. Dr. Lewis.
Yes, hi. Good afternoon. Medical standards met early this morning, and we bring forward 2 seconded motions for the committee's consideration, and then a few items of discussion and moving forward. So the first protocol coming forward as a seconded motion is approval of the New York City protocol change to add tetracaine to the eye injury protocol. Tetracaine is already in the burn protocol in New York City and is also in the eye injury protocol in the collaborative protocols. So there's very little discussion, and that comes forward as seconded motion.
Any discussion? Okay, Val, I believe we need a roll call vote.
Thank you. Okay, Dr. Bart,
Yes.
Dr. Berkowitz? Dr. Cooper? Yes. Dr. Cushman?
Cushman, yes.
Dr. Daly?
Daly, yes.
Dr. Doynow?
Doynow, yes.
Dr. Isaacs?
Yes.
Dr. Kugler? Yes. Dr. Lynch?
Lynch, yes.
Dr. Markowitz? Dr. Marshall?
Marshall, yes.
Dr. Olson?
Olson, yes.
Dr. Talbot?
Talbot, yes.
Dr. Walters,
Yes.
and Dr. Winslow.
Yes.
Motion passes.
Okay, thank you. Dr. Marshall?
Yes, thank you. So the next motion that comes forward is about aligning the New York State BLS protocols with the collaborative protocols. A document was in Boardable which outlined differences between the state BLS protocols and the collaborative protocols. And as pointed out by one of our members, most of these changes are not medical in nature. So that discussion happened, and then this comes forward. The committee recommended to accept all these changes and bring that forward as a seconded motion. And then I'll have some other information after the vote.
Okay, any discussion? Okay, Val, another roll call vote, please.
We're good. Dr. Bart,
Yes.
Dr. Berkowitz, Dr. Cooper, Dr. Cushman,
Cushman, yes.
Dr. Daly,
Daly, yes.
Dr. Doynow,
Yes.
Dr. Isaacs,
Yes.
Dr. Kugler, Dr. Lynch,
Yes.
Dr. Markowitz, Dr. Marshall,
Yes?
Dr. Olson,
Olson, yes.
Dr. Talbot,
Yes.
Dr. Walters,
Yes.
and Dr. Winslow.
Yes.
Motion passes.
Thank you, Val. Dr. Marshall?
Yeah, thank you. So as a result of that discussion this morning, we had the discussion about the establishment of this New York statewide BLS protocols many years ago, approved by this body, and some of the regional changes that have occurred over the years based upon region-specific needs. And so what we agreed to do was put together a working group to look at the statewide BLS protocols, the collaborative protocols, and the unified protocols to see how we can get to one set of protocols. The concern is that where do you refer a provider to when they want to look at BLS protocols? And I believe it was Dr. Olson said it should be the same, regardless of which document you look at when you're looking at the BLS protocols, not the ALS protocols. So this task force, this working group will work on that and bring information back for the next meeting. Other items that we discussed were the protocol approval update process, which will also be worked on again and brought forward. There was some data requests from the committee to the department, which we will have for the next meeting. We did have a discussion based upon length-based pediatric resuscitation tape and conflict with our existing protocols, and that there's at least one medication that conflicts between the tape and the protocols in one region. And so EMSC has volunteered to look at that and come back to medical standards and SEMAC with their recommendations on how to move forward with that. Continuing the pediatric discussion, we talked about pediatric CPAP and high-flow nasal cannula, especially with the viral respiratory surge that we're seeing. And the challenge for some areas is how do you transport these critical pediatric patients long distances when you can't, maintain high-flow oxygen on an ambulance. So that will also be looked at by EMSC. And lastly, we had a discussion on an article from last month on defibrillation strategies for refractory VFib, which showed that double defibrillation and vector change defibrillation resulted in improved hospital discharge and outcome of patients in refractory VFib. We didn't there were no motions on that, but it did come up for discussion, and we should probably further discuss that because there's at least one state that's already implemented that process. And apparently we had that in our protocols years ago and took it out. So more to come on that. And I'll answer any questions, and that's my report.
Thank you, Dr. Marshall. Any questions? Okay, Dr. Cooper, EMSC, if you would.
Excuse me, sorry. As Dr. Is that better? Thank you. I never had that problem before, you know, having myself heard. As Dr. Marshall mentioned, EMSC has, with the assent of the SEMAC, tasked itself with review of the pediatric medication determination methodologies that are out there, such as Broslo-tape, Hentevi, and so on, with specific instructions from the CMAC to ensure that there is, synchrony between the various methods that are there, so that our providers are not put in a bind thinking that they have violated protocol if one of these devices suggests a drug dose which is different from what is currently in protocol. We'll be looking at that at our next meeting. We will also be looking at the issue of high flow nasal cannula, CPAP, and BiPAP, and its potential applicability to pediatric patients, particularly over long distance transports. There are numerous problems with that, as many of you are aware. The ability to carry sufficient supplies of oxygen and to have all the various mask sizes that one would need and cannula sizes that one would need could be very problematic, not to mention that our providers may not have a wealth of experience in dealing with pediatric respiratory conditions. But we will be looking at that at our next meeting. We were tasked by STAC and EMSC to look at the new American College of Surgeons field triage guidelines, because they are substantially different from the previous version, more in construction than in content, but we were tasked to ensure that pediatric issues were appropriately addressed. We will be doing that prior to the next meeting. We were also tasked, as you may recall, with looking at the proposed pediatric and adolescent agitation protocols. We held a joint meeting between the EMSC folks involved with this project and the collaborative protocol group, which was a productive meeting, no question about it. The upshot of the meeting, as many of you are aware, is that there'll be a major focus on developing educational materials to support any potential protocol changes. Dr. McAvoy did briefly comment on that during his report. I might just add that for those of you who are unfamiliar with this, particularly my emergency medicine physician colleagues, in the November issue of ACEP Now, there's a large spread on the issues of pediatric de-escalation, which figure prominently in the proposed protocol put forward by EMSC that was modified by the collaborative group. But it's our hope and belief that we will be able to develop training materials in a fairly prompt fashion if we find in reviewing the various educational programs that are out there don't meet the needs of our pre-hospital colleagues here in New York State. And finally, I just want to comment briefly on the Pediatric Emergency Care Coordinator issue. Director Greenberg did comment on that in his report, but new this time around will be is the need to have a Pediatric Emergency Care Coordinator in the emergency department as well. And I'll turn the platform over to Amy Eisenhower to comment on that fairly briefly before taking any questions. Thank you, Amy.
Thank you, Dr. Cooper. And so I believe our last SEMAC and SEMSCO set of meetings, I briefly mentioned the American College of Surgeons has made it a requirement to be trauma verified that you have a pediatric emergency care coordinator, and talk a little bit about what EMSC recommends. I have, well, through Peter, because of course I was sick during the meeting, I presented to STAC on what those criteria are. And since our last CMAC and SEMSCO meeting, the NOFO for the EMSC grant coming up over the next 4 years has come out, and this plays a large role in their performance measures. So one of the performance measures to meet for the grant is to have an ED, pediatric emergency care coordinator, and also to have pre-hospital pediatric emergency care coordinators, which we already have. And some work has already been done in the national region. So there is a East region for EMS for children. We are a component of that. And they have developed a pediatric recognition / PEC program for in-hospital use called Always Ready for Children. And we hope to avail ourselves of the work already done by my fellow program managers. Mainly Mark Minkler from Maine has really fleshed that out. And so I hope soon we will have our first group meeting with the people that have indicated they'd like to be involved. I know that we are waiting on a representative from DOH from hospitals, because this does involve in-hospital, and we want to include everybody that will play a part in that role. So I think that we're just waiting for a representative, and I'll be sending out an email with some potential dates so we can pick our first meeting date. And so if anybody else in here is interested in joining us for development / clarification of the program that has already kind of been working in other states around our region, I would be happy to have you join us. So just let me know. Thank you, Dr. Cooper.
Thank you, Amy. Any questions for me or for Amy regarding the activities of EMSC? Hearing none, thank you, Dr. Doino.
Thank you, Dr. Cooper. All right, moving along, any old business anybody wants to bring up? Go ahead, Dr. Martin.
Hi, Joe Bart. Just any progress we've had on the submission of the state EMS medical director position and what we've heard about that.
I'll leave that for Ryan Greenberg.
It's literally on my list, things to discuss.
It wasn't on your list?
No, it is, literally.
Perfect.
But we were waiting for old business. So it is progressing through the process on our side, at about the pace that I thought it would. So my goal is hopefully probably this summer to have an idea of really, where that is and when, getting out and stuff like that by the time it gets through the many processes it has to in order to kind of create that new position.
Was there any feedback in particular? I know several members of this group put that together as far as the description. I don't know if there's any feedback at all that you were willing, even offline, to share with us to just try to keep us involved in the process if we can.
Sure. I don't think there was any specific feedback at this point. I do know that the recommendations in that document was move forward as well.
Thank you. I had one other thing, and I know this has been in the pipe for quite some time here, but is the Bureau intending on putting out any specific correspondence for maybe those individuals who weren't completely prepared for the AEMT transition to the loss of the intubation, particularly in their scope of practice? I know as medical directors were involved in that process, but there are people that maybe don't know where that came from. I'm just wondering if something was coming out from the Bureau that we should echo that, or if individually as medical directors, we should be creating our own content.
Nope. Excellent point. It's actually something that came up over these 2 days in conversations. So we will be working on a policy statement with the other updates. And realistically, that will come out with the February meeting. So that's where it will come out.
Thank you.
Any other old business before we move on?
Do you want the mental health to go now?
I was going to do a new business, but
Sure, either way.
we can do mental health now. Jenny, if you'd like to.
Brilliant. Thank you so much. Folks, I am really grateful to everyone who has helped us get where we are so far. It's significant. I had a recent evaluation. Every student who takes this course submits an evaluation, and one of them recently came back specifically thanking the state and everyone involved for promoting this kind of education. And I think that was huge because support is a massive part of fostering resiliency. So if our providers feel supported by us giving them this education and making these opportunities available, then that in and of itself will help foster the resilience of our providers. The providers that have taken courses have come from many different program agencies. There are still some that have not yet had courses there. I think that speaks to the oversaturation of continuing education, the geographic limitations, and just some other situations going on. So if you are from the M-Star region, I would love to put a class together for someone in there. We do need to reschedule something for Southern Tier. They had something scheduled and we had a very low enrollment, so that needs to be rescheduled for hopefully a better time in the year. Central New York as well I'm looking for. Westchester we anticipate in the spring, and Suffolk County possibly later on in the year as well. They suffered from oversaturation. Just because we have already done this class in your region does not mean that we can't come do it again if there is interest. Originally, I had reached out to program agencies to help facilitate this. Turns out program agencies already have a lot on their plates. So what was really great was going directly to agencies and squads and being able to offer this in-house and meet their providers where they are. We found that providers responded very well to this, and we had some very high numbers of people enrolled. So, for instance, Oneida County has already hosted 3 separate classes. So providers in Oneida are feeling pretty resilient and grateful for this. I also really want to appreciate people speaking towards the de-escalation, because we, in that same survey, ask providers what else they would like to see. And with the time limitations of the course, they get a very 101 sense of de-escalation, but they are in fact actually asking for more of that. So collaboration is huge. I'm happy to lend whatever I have to those of you doing that. And I think that's it. Ryan, is there anything else you wanted from me?
Jenny, how would people get in touch with you that are looking to get in touch with you for this program?
All right, get ready to write it down. I'm going to give you my, or you could just email Ryan and he'll forward it to me if that's easier for you.
I think it might be more successful if they emailed you directly.
I agree, but I think that you're selling yourself short. I think you're totally capable. So if you'd like to get a hold of me, Jennifer.Solomon, Salomon, it should look like the fish, salmon, but with an extra O in the middle, at health.ny.gov.
Thank you very much.
Wait, one more. I did so good. On the back table, Amy has been absolutely instrumental. There is a poster speaking to a universal approach towards mental health. That poster has a QR code which will link your providers to our resources, especially if you come from an agency where your folks are too cool for this, then I implore you to put it up, because those are exactly who we need to set the standard and model the behavior to be able to access these resources, because like I said before at the beginning, resources foster resilience.
And Ryan has a poster up if anybody would like to come up and scan Ryan.
This is a big initiative too, actually, on the posters. The posters are in the back table, but if anybody does need more for their region or want more, these are also going to be sent out to all the EMS agencies. So it is really designed, and where the QR code goes to is designed for for an agency. So for a provider who maybe doesn't know who to reach out to or how to reach out to them, something that they can quickly walk by, see it's there, scan the code. It goes to a web page that we created. Thank you to Amy Eisenhower for doing a lot of legwork on that one. And we'll continuously update as more resources become available. This is very EMS-centric, or emergency services-centric, I would say. So, the point of this program is to get out to our providers and to let them know if you need help, there are options, and if you need help that are specific to understanding your needs. We have many, many of these posters. Like I said, we're going to send them out to each of the agencies. But in addition, please don't be afraid to take a large handful. We didn't bring as many this time, but at the next meeting we will be plentiful. And please take as many as you think you need. Thanks.
So I also know in the future, we're working on having a web form for requests for that, but you can email me, and if you need many of them, I can get them shipped direct to you if you don't want to wait for the next meeting.
Okay, thank you. Any questions for Jenny? Okay, moving along. Some other new business here. Just to report, just so you folks are aware, at the STAC meeting, Dr. Simon and Dr. Tepperman had rather harsh comments about this group's protocol for TXA. They were invited to come to this meeting, or their representatives were invited to come and discuss it with us if they had any questions. And as far as I know, neither of them or their representatives are here. So my assumption is after further review, they found that their concerns were unfounded, and put that to rest. Dr. Daly, do you have anything to say?
No, Dr. Dillon, I would actually just like to apologize. I was at EMS World Expo and could not join you for that meeting. I'm sorry I could not remind them that indeed the STAC had agreed with the process that was moving forward at that point. So I'm sorry that turned into a less than collegial experience for you.
Thank you, Dr. Daly. Okay, moving on, EMS wait times. As all of you know, we are telling our EMS agencies they need to be at the patient's side within minutes, yet we're getting to the point now where multiple EMS agencies are being tied up in hospital hallways waiting to unload their patients, sometimes for hours, which has presented significant issues for EMS response time. Some agencies going to first and second mutual aid in attempting to get an ambulance to the patients. That resulted in a local group of EMS providers who met, and one agency came to a decision that they vetted through their legal representatives as to what exactly they were going to do if they could not unload the patient, and if they were going to be there for a prolonged period of time, what was going to happen. I won't go into specifics. If anybody wants to see me after the meeting, I'll be happy to give their contact information. They said that I could certainly do that. That did prompt one of the local hospitals to come up with a pretty reasonable program to get EMS agencies to unload, which they actually started this week. And I was going to ask Dean Romano, who is EMS coordinator for that hospital, to explain what they did, and I'm sure he'd be happy to answer any questions. My understanding is that specific hospital had 74 ambulances over the period of time that they started this, and it worked out pretty well.
Okay, so I'm from St. Peter's Hospital and St. Peter's Health Partners, and at St. Peter's and Albany Med, we kind of both have the same problem where we have ambulances stacking up. So at St. Peter's, we did a pilot. We've begun this. We're using it on Mondays and Tuesdays to troubleshoot, try it out, tweak it that week, and then modify it for each following week. The very first week, on the very first day, we saw a 33% increase in our ambulance volume that has nothing to do with the pilot program. It just happens to be that volume that day was incredibly high. And some of the findings that we found were the goal was to build almost like a waiting room for ambulances at the back entrance, along with the waiting room for the walk-in patients at the front. And so we've created this space, and with that increase in volume, we quickly overrun the resources that were available. However, it did create an improvement in the flow. The EMS crews definitely appreciated the additional effort, and it did actually help the flow through the department a little bit. There's lots of opportunities to make some more improvements, but it is just one effort in a whole list of problems that we're trying to solve. So we did make some progress, and we are going to continue to work through this kind of like an EMS staging offloading area.
Dean, can you explain who's in, how that would work, and who's staffing, like what that would look like a little bit?
No, because actually it is changing. Yes, certainly. So right now, I'm going to just talk about the EMS side of it, not the waiting room side of it. So right now, we staffed it with an RN. We have lots of different scenarios on how we're going to try this. We're thinking we can staff it with an RN who can take the report and move the patient from the ambulance stretcher to the emergency department stretcher, and then move the patient into the department and swap, move around stretchers. We've talked about a model where we're using an LPN in the back, and the charge nurse RN will take report. The LPN can stay there with the patients and move the patients around as needed. The nurse, regardless if it's an RN or an LPN in the back staging area, is not taking that patient as an assignment. It is kind of a hold area until the nurse who can take that patient is, got an available bed.
And just curiosity, is there a mid-level or provider seeing them at all in that offload time, or is it not till they get to the back?
So this is not yet a treatment. This is truly a waiting room and it is not a pit type of a process like we're using in the front of the house. And I hate using the terms front of the house, back of the house for ambulances and walk-ins, but you get the idea. But we have talked about the possibility of using that. A lot of different scenarios, and there's nothing out of the balance here, trying to figure out the best process for this.
Thank you, and thank you for sharing it. Is there any other members that are in their hospitals doing anything similar or anything to help in decreasing those times or a different approach?
If anybody has any ideas, I think all of us are open for them. Dr. Abert.
Thanks. So, I commend you for this program. In full disclosure, I have some relationship with that health system. But we're seeing this all over the state and all over the country, quite frankly. And it's not that, our ERs want to help our EMS colleagues and all unfold as quickly as possible, but as the recent New England Journal article, the emergency department canary in the health system eloquently pointed out, this is really a problem of hospital throughput and hospital efficiency. And I think there's lots of things we can do beyond these temporizing measures, which will help. But for example, during COVID, and it's still in effect, the health department requires hospitals to report inpatient bed capacity, and that's how they make their decisions as to if they can continue elective surgeries or not. I would say that that's not the right measure, and that there really should be some measure of ED in there, whether that's percent of ED beds occupied by inpatient holds, or left without being seen rates, or wait times. And I really think this body should work with the department and the incoming commissioner to really try and get a meaningful measure of hospital health and efficiency, and that comes from the emergency department, not how many total beds you may have in the hospital, whether staffed or not. So I think that's one concrete action we can take. Another one is in the realm of diversion. I really think we need to get a handle on diversion, and hospitals should be required to report diversions to the SOC or the SOC designee, so that we really can have an understanding, working with the Bureau and with the health department, as to what's the capacity of the system currently, and are EMS providers being asked to go 60, 80, 100 miles out of their way with patients to try and drop these off. So again, I applaud these efforts, and I think a lot of our hospitals are trying to be creative and think out of the box as to how to help offload EMS in a timely fashion. But this is a hospital problem and not an emergency department problem, and I think this body should point that out to the department. I think we run the risk, though, with some of these EMS agencies, and I understand the frustration, but creating an agency-specific policy is a challenge for our hospitals because they don't know how each agency is going to act or what their plan is to leave the patient there. So perhaps a regional approach would be better there as well. I know I threw a lot out there, but thank you.
Is that a motion, or is that just a suggestion?
I will phrase it in the form of a motion that the SEMAC send a letter to the commissioner or designee asking that the department develop an emergency department-based metric to determine hospital status and ability to continue elective surgeries.
Okay. Did you get that, Bill? No. Okay. We need to have it slower.
Sorry. What? I'm from downstate. I'm sorry. So that a letter to the commissioner or designee, because right now we don't know who that's going to be, but the commissioner, that the department reevaluate the current criteria for hospitals continuing elective surgeries. The current criteria for hospitals to be able to continue elective surgeries and develop an emergency department. Mm-hmm. to continue elective surgeries and develop criteria that consider inpatient burden on the emergency department. And ED capacity. Inpatient burden on the emergency department and available ED capacity. Capacity.
Hold on it for a moment. Do we have a second? Dr. Marshall seconds it. As far, what's that? No, I was going to say, at this point, Mark Philippi, would you like to talk about what you've done with this before we vote?
As a point of discussion on this matter, but also just kind of reporting out on some of the things that have been done, thanks to the efforts of Steve Crow and Dr. Morley from the department, we were able to meet Director Greenberg and I with the principals from the Public Health and Healthcare Policy Council, which is our sister council, actually predecessor council, I understand, was helpful in formation of the SEMSCO and the SEMAC. The physician leaders there were very interested in what we were talking about as far as emergency department hold times and offload times. It is a topic that is very concerning to Dr. Morley, and by extension, I'm sure the commissioner and the staff at the department. We have on good information from Director Greenberg that FIPIC is interested in speaking with a delegation from the SEMSCO. At the request of Dr. Doynow, I'm going to ask for some physician leaders from this group who may wish to help assist us with forming our thoughts to do that and potentially be involved in the presentation. But certainly depending on the outcome of the SEMSCO elections this afternoon, I will be in a different position, but I'm still willing to help and facilitate this discussion. As we're trying to do this, I would have an ask of this group as physician medical directors to speak with your agencies to try and develop some data. And full credit to the Bureau's data analytics staff and Chief Brody. I know that agencies sometimes have different data analytic platforms available to them. They might help us to develop information along the lines of what are your hospital hold times, what is the unit hour utilization they're being involved with being held up at the hospitals. This is some information that we could very much use to make our case. But that's something that's in the works. I don't have a firm date on when that might be. So that's all I have to report on that. Thank you, Doctor.
Thank you, Mark. Go ahead.
Hi, Jonathan Washko, hospital representative. I would throw out, first off, NEMSAC is working on this issue, and advisory was sent to final last NEMSAC meeting associated with this particular issue. There's 3 specific recommendations that the NEMSAC is making to the federal government because this is a national problem. The biggest thing has to do with relationship building, and pretty much all 3 points are associated with relationship building. And so potentially it might be worthwhile to consider putting a group together from the SEMAC to potentially engage either Haney's or some other group that we potentially can work with from a state level to see what we can do to help solve this problem, identify what the issues are, share the data, open a dialogue, something along those lines.
Thank you. Go ahead, Steve.
Good afternoon. I get to wear, Stephen Kroll, I get to wear a couple hats in my world, and I'm going to put on my hospital hat right now. I serve as the chairperson of the board of a hospital in New York State, and I want to take something John said and connect it with something Dr. Rabert said. John talked about how this is a collaborative process. We have to work as partners with hospitals, and we are the regulatory body of EMS, and what Mark Philippi just connected us with is the regulatory body for hospitals. Article 30, Article 28, meet each other, talk among yourselves, see if you can come and find some solutions. And I think bringing groups like Haney's into that and the Medical Society and the emergency physicians associations all make sense. I do want to speak, though, on your motion, Dr. Abrich. Hospitals in New York State are losing hundreds of millions of dollars because of the cancellations of elective surgeries. That is feeding into this vicious circle of a problem, which is we don't have money to hire the personnel we need, to improve the nurse ratios, to be able to open up more beds, to be able to do ER throughput. I think us sending a letter, and I'm not a voting member, I'm a non-voting, but for us to send a letter that says you ought to have a metric as to whether or not we're going to stop doing elective surgery actually feeds into the hospital problem. My hospital system has lost somewhere around $50 million in operations so far this year, and we're one of the ones that is doing better than others. There are some that number's in the hundreds of millions now. If we suggest that the metric to suggest is limiting elective surgeries because of the throughput issues, we actually put more pressure on the hospitals in a place where they just don't have the money to make those hires. So I think your intent is correct that we need to be sitting down with hospitals and talk about what is the right metric, but I don't think this one necessarily is going to get us where we want to go, because no hospital wants to have these throughput issues. We actually can be part of their solutions as partners. You know, things that are being talked about are like community paramedicine-like things, right? How do we keep people, how do we get less people in the ER that don't belong there? Dean described what One Health System is doing. I think we need those collaborative discussions, and I think we're not going to get ourselves very far if we put the hospitals in a position of hearing them say, they want you to do less surgery so you can get patients out of the ER. Now, I know there's a lot of inside hospital politics that this relates to, right? And I don't want the EMS community to sort of set up a fight inside the hospital, right? ER versus inpatient. They already have that fight. I don't want us to be making it worse. So that's my thoughts.
Any other discussion? Dr. Raybridge?
So I understand what you're saying, and I'm fully aware of the hospital's financial situation. I would submit, though, that we have, over the past many years, emergency medicine organizations, others have spoken with the hospitals. And, hospitals are driven by certain motivations, which, let's be honest, the ER patient waiting in the ER is not the highest provider of income for the hospital, to put it that way, right? So, throughput and hospital holds have been an issue before COVID. It's coming to a crisis level again now, but, we've been having this discussion for 30 years. So, I will give you that, maybe canceling elective surgeries might not be the exact way to go about it, but until there is a motivation for this to be fixed by hospitals and health systems, beyond let's sit and talk, I'm not sure we're going to get anywhere.
Okay, let's see, Dr. Walters, I guess, was next.
Sure.
We'll move over this way next.
I just wanted to, I think, echo what Dr. Raybridge said, and Mr. Kroll, I appreciate what you're saying. I think the intent here, nobody wants to see surgeries canceled, right? We know that affects patients, it affects hospitals' bottom line, but we also know that some hospitals are not as good as others at looking at ED wait times, EMS offload times, boarding in the ER, and I think one of the things that we have seen in the last 2 years through COVID is that if there is a risk of canceling elective surgeries, all of a sudden hospital administrators pay attention to whatever metric is attached to that every single morning. And I think trying to put some type of incentive, like Dr. Raybridge suggested, that will get the attention of the hospitals and make it a motivation for them to improve that throughput or to look at these numbers and look at the system as opposed to not just their financial incentives. I think that is the goal. It is difficult probably to define a way to do that without punishing someone in some way. However, to be honest, sometimes that stick rather than a carrot has to be put in place to draw that attention of our hospital administrators.
Thank you, Dr. Walters. Marianne?
Marianne Petoro with New York State Emergency Nurses Association. I'm not a voting member, but just what Dr. Raybridge said, I mean, I know elective surgeries, canceling them may help some of the problem, but the other biggest problem is there's not enough nurses out there to take care of these patients. So he talked about throughput. Throughput is a major issue, so if there's no staff upstairs to take care of the patients on the floors, we're not going to get our patients out of the ER because they're not taking them on the floors. They're closing the beds because they don't have the staff to staff those beds and to take care of all those patients. So we're backlogged with all these patients and holding them because they think the ER is the place to do it. And then EMS comes in, they're backlogged. It's a major throughput situation. And I think maybe what we need to look at, or this body needs to look at, is how can you help improve the nursing shortage and work together, and also with a community paramedicine. I know that's a major thing, but that's the key.
Dr. Daly, I believe your microphone's on.
So I very much appreciate what Dr. Raybridge is suggesting. But I think one of the things that our patients in the community are still suffering from is some of the restrictions on elective cases that were started through COVID. The idea that if we cancel elective surgeries, it somehow increases capacity in a hospital system is false, right? Most elective surgery is same-day stuff. The staff that takes care of patients in a same-day situation isn't going to suddenly decide that they want to go work on floors instead. And during that shift in staffing and trying to move nursing staff from one place to another during COVID, we actually lost a significant amount of nursing capacity within our hospital. The reason that you want to do this is absolutely fantastic. The way to get there is not by limiting elective surgery. The department's stick here would be a drastic move. The other thing I'd like to point out is that while FEPIC is indeed the planning for hospitals, right? This is the planning and the committee for emergency departments. We are responsible both for emergency departments and for EMS, advising to the commissioner. I think advising the commissioner to look at things like NEDOC scores in terms of hospital capacity or emergency department capacity, great idea. Make it a modified NEDOC score so it's based on actual capacity, not reported capacity. But we cannot start impacting elective surgeries in these days of real fiscal disaster for hospitals when it's not going to ultimately decrease throughput times in our emergency department and increase capacity in our EDs.
Thank you, Dr. Daly. Dr. Marshall?
Thank you. So as CMO of a large level 1 trauma center in New York City, I deal with this on a daily basis in terms of what's the balance between the inpatient and the emergency department. We always have patients boarding in the emergency department. We always have patients waiting for surgical procedures upstairs. There's no easy answer, but perhaps in considering whether or not a hospital or a health system should reduce the elective surgical volume because of a particular reason, they should include ED metrics in that discussion. Not that you have one ED metric that determines it, but they should also include the emergency department in that decision-making process. I think that, my problem in my facility is not throughput, it's not nursing staffing, it's anesthesia staffing. And so, some of the things that I've had to decide are, can I continue to do elective surgery if I don't have anesthesiologists, right? I mean, those are my challenges, but I think that adding an ED metric to that whole decision-making process may just help us better understand throughput through the hospital. Thanks.
Thank you. Dr. Raybridge?
Thank you. And just to your comment, Dr. Daly, I mention elective surgeries because that currently exists and I'm not suggesting that that's the only thing to do or look, and I would be happy to amend the motion or look at other things, but I think there has to be some motivation for hospitals to help fix this beyond just, we're going to meet and it would be great if you could work on your throughput. But I hear your concerns about elective surgeries, but it is currently what the department is using based on capacity to make that decision.
Dr. Berkowitz?
So I think none of us will deny the importance of incentivization. I mean, that's what we're talking about. How do we incentivize the behaviors? And that's a real challenge. I think that we're talking about sticks, and I think we should be looking for carrots. What can we do within our health infrastructure to incentivize in positively for hospitals? I don't know what we can do. But I think that will support more growth of the healthcare system, which is what we need. Future state, we need healthcare to grow. There's minimal capacity in many areas in many ways. Access in general to healthcare is an issue. So I think that if we can incentivize appropriately, we'll be incentivizing growth. I mean, hospitals are not making the margins that other players in the healthcare industry are making. So I agree that the kind of stick is not, regardless of whether it would work, and it would likely cause all sorts of other untoward ramifications. We know that when we make decisions, you think you make this great plan to incentivize behavior in a certain way, and you look at it 3 years down the road, and you're like, why are people doing these weird things? And it's because of what you put together. In general, I think when you have positive incentives, you have less of those behavioral ramifications.
Thank you. Dr. Kruger, you had comments or not? Nope. Dr. Phillip? Mark Phillip?
I think Dr. Cooper was first.
Dr. Cooper?
Thank you, Dr. Donow. Back in 2005, I believe it was, when Article 30B was introduced for action by the legislature at the behest of Assemblymember Godfrey, chair of the Assembly Health Committee. Several of us were able to convince him that it was really important to give this body a role in advising the department and the commissioner about issues taking place in the emergency department, because there was really no other place where those issues were being discussed or advice being provided on a formal basis. Assemblymember Godfrey saw the wisdom in that. Article 30B explicitly does speak about SEMAC's role. As Dr. Daly has just pointed out, there was a task force that was set up. Dr. Marshall may remember. He served on it, I believe, back in 2006 or 7, thereabouts, under Director Ronsky. A couple of meetings were held, but nothing further, happened after that point. But I think that the issue we're discussing today really points out the wisdom that Assemblymember Gottfried, brought to bear about making sure that there's a better interface between the emergency department and the pre-hospital end of things. And in some ways, this mirrors the approach that has always been taken by EMSC, which was envisioned as a program from the get-go that focused on the emergency patient through the fate of the emergency patient through the entire system, or the entire course of care, from prevention, access, et cetera, all the way through to rehabilitation. Including the proviso that this body has a role in advising the commissioner of the department about emergency departments as well as EMS, I think was a fundamentally important first step in that direction. And I do think that this body is very well prepared to think about those issues, not just about the current crisis, but moving forward. I think everyone has made great points. I just can't help but remark that if you cancel elective surgeries, I'll have more time to go to meetings talking about why we're canceling elective surgeries. So maybe with that in mind, you'd like not to cancel elective surgeries. But be that as it may, a lot of good comments made today. But as Dr. Daly also has wisely pointed out, most surgery these days is elective and ambulatory, and the long-haul surgery patients, by which I don't mean long-haul COVID, but long-haul surgery patients that are in for several days, those patients are very, very few and far between now, except in our trauma centers, and no one's going to deny them access to care, at all. So I will stop there, but I just want to encourage us all to continue at this level to see if we can't help our colleagues statewide find some reasonable solutions or share best practices, as we're attempting to discuss today. Thank you, Dr. Dornell.
Thank you, Dr. Cooper. Mark Philippi.
Thank you. I really appreciate the conversation as I kind of go back to some of the information that I brought forward earlier, and to Dr. Raybridge, we have a motion on the floor, so I don't want to take up too much time from that. But I think at the end of the day, what I'm hearing is that we need to kind of revitalize this task force concept, that we need a couple of things to do that, one of which is some transparency in the information that we're obtaining. Not just from the agencies represented here, but also from the hospital systems. For example, one of the hospital systems in my region has an internal document that someone accidentally shared with me that has some very good information about their ED boarding and hold times. So they are self-reporting within their own institution their ED hold times and boarding and nursing staffing. And to Mary Ann's point, not to get into the politics of it, but how many nurses on the floor are actually handling how many patients? And we all know that the ED nurses are often handling way more patients than a floor nurse would. So what do those numbers look like? If we are to incentivize this in some way, I think part of that is getting information that may require a demand or at least a polite request from a governing body. And I think that we could potentially influence that by a joint venture between us and FIPIC. But again, I know this is kind of off Dr. Rabridge's motion. I just wanted to throw it out there that at some point, I think that's where we need to head.
Don, go ahead.
Sorry, I'm not a member, but Don Hudson. So in acknowledgement that we need to work within what we can control as the regulatory body, in this case SEMAC, SEMSCO, and whatnot, and in acknowledgement of all the problems that our in-hospital partners are encountering that are far beyond even their control, if not ours, what could we do as EMS? Is this the springboard issue that really should be used to drive community paramedicine, ET3, and alternative destination in an effort to work with our in-hospital partners to decompress their facilities? We keep feeding this machine that we know is breaking, and then we're amazed at the poor product that comes out, in this case meaning people. So what would the true EMS role be here? And I don't want to stop feeding our hospitals patients, but we need to get the right patients to the right facilities, as we all know, and how do we do that? And I think that is a topic that has somewhat stalled due to other political and misconceptions, both within our own community and outside. So I would just say, strike while the iron's hot.
Thanks, Don. Yes, go ahead.
So I just want to say thank you for all the feedback and even just the concepts, the ideas, and different things. And in thinking through different ideas and conversations that I've had, one of the other conversations this weekend was also about just transparency on a number of different things. And so maybe it's not the elected surgeries that stop, and we all understand the pain and the things that happen with this. But it's also, we live in an ecosystem. It all affects one another. I think Mary Ann spoke about it. One backs up the other. We all know that one. But step one in Dr. Raybridge in reporting and maybe having to post, how long your offload times are, how long your average offload times are, because good, better, and different. Sometimes competition, around it does help, or at least it makes it recognized when you look and say, fill in the blank, Steve Kroll's hospital, has 10-minute offload times, and Greenberg's hospital down the block has 60-minute offload times. And I'm walking over to Steve going, how'd you do that? Or maybe St. Peter's, depending on how that program goes. So, maybe some of that transparency is a recommendation that doesn't have the same other impact and financial impact, but has, a step in a direction of at least having someone look at something on a regular basis. Again, just ideas for steps.
Don?
Go ahead, Steve.
This has been a great dialogue, and there are a lot of really motivated people around the table. And Dr. Berkowitz, you mentioned both the carrot and the stick. There's a combination of things we can do. A transcript of this should feed right into the conversation that the SEMSCO and SEMAC have with the Public Health Council Planning Committee, which we now know is going to happen. They occupy the same role. They're our sister body. So if we can take this energy and conversation, and the point Dr. Daly made, that we are not just EMS, we're EMS and ER advisory body to the commissioner. You all met Dr. Morley, who was here at our last meeting, who has sort of been the facilitator of this. He's a heartbeat away from, he's in the same, he's a deputy commissioner, right? He's part of that commissioner's executive team. We can make this into all, Don mentioned, some other things that play into this, right? The community paramedicine. We really do have an opportunity as a body here, and I would say the CMAC should reach out to the SEMSCO, it should be together, to make this Public Health Council thing not just a one meeting, but make this, here's the regulators of one side of the equation and the regulators on the other side of the equation. Let's make it a 3-month, 6-month, 9-month project. What are we going to come out with and do? Because I think that the transparency is important. I mean, I think you raise a good point about what are the metrics we ought to look at. The other thing I'll mention is the Public Health Council, because they're the hospital system, they got a pretty big staff of people. You take that staff of people and you combine them with our staff of people that work here, there's a lot of data to be mined, and there's a lot of public policy to be built. And I think that, Ryan, and if Ryan and his counterpart at the public council side are able to work together, they really could facilitate great conversation. So I think that we should bottle whatever happened here today when that meeting happens with the Public Health Council folks.
Thank you, Steve. Any other comments? So I would recommend that anyone that's interested in working with Mark Philippi, you let him know, that being physicians and EMS providers, if that's okay with you, Mark. And they can meet with you, I guess, after the meeting, share information. Dr. Raybridge, did you want to modify your motion?
I'd actually like to table it to the next meeting if I could, and hopefully this can happen before then and we can get some progress.
Okay. So we will table that motion until the next meeting. Okay, any further discussion? Dr. Cooper?
Thank you.
Yes, our parliamentarian is not here today, unfortunately. Okay, so we'll table it from Dr. Cooper.
I apologize for stenographer. Can you just repeat that on your mic? Turn on your microphone and repeat it. Just want to make sure she was able to record.
Thank
Thanks.
you, Director Greenberg. I commented that I don't believe under parliamentary law that a maker of a motion can table his or her own motion. He or she can withdraw it, certainly. But since the motion's been made, I don't even know if it's been seconded formally. But I'm assuming that it has been formally seconded, and I will therefore move to table to the next meeting, which is a non-debatable motion.
Okay, it was seconded, and yes, we'll table it till the next meeting. Okay, that being said, next is quality metrics.
Thank you, Mr. Chairman. Val, if you could put up a presentation. I was asked to deliver a brief presentation on where we are with the Quality Metrics Committee. We talked about this last time as well. I have to give a huge shout out and thank our committee. They've done just a tremendous amount of work. I appreciate all that work that they've done. We have a QI manual that's about 40 pages long that really is pretty detailed as more of a reference document. A quick start guide that's about 4 pages long, and that really details the things that folks can do at their agencies. These are all sort of the how to measure what we're doing with data, and this is all onboardable as draft documents for everybody here to see. And so what I'd like to do next is, hopefully, if this will all work, give a brief presentation of what we've got now as a quality measure. We looked at the ability to measure blood glucose on stroke and TIA patients. And so Val, if we go to the next slide.
I think maybe just give it a minute to...
Sure, okay, we're going to let it warm
get
up
there.
here.
The projector had to be restarted.
Gotcha, sorry about that. And so as we move through this, I just want to highlight what's possible and what we can all do. And so these are the items that we want to quickly go through in this presentation here. Next slide. The manual itself has quite a number of different areas to it. Great, thank you for making that larger on there. Next slide. Manual has all these different areas here, and so this really is more of a detailed reference document. I can't imagine that everybody is going to read through this manual unless it's late at night and they'd like to get to sleep, which I appreciate. But there's a ton of good information in here that this team really looked at that's nationally vetted data and reference material. Next slide. The quick start guide here has a little bit of a briefer approach to it. I'm going to take you through that process very quickly. And so these are the components of the quick start guide. Again, these are all onboardable. Next slide. So we're looking at the state measure 06, and this is a stroke or in TIA patients receiving blood glucose monitoring. The denominator of this are the people that responded on 911 call for a stroke or TIA patient. The numerator are those who received blood glucose measurements. Next slide. It's fairly easy to do on the state bridge, and this looks a little scarier than it actually is, but we're taking a look at all of the potential data points and funneling them through the state site to come up with this measure. The top piece of this are some of the larger components of it, and then the smaller individual data points are below. Next slide. And so we looked back at 2020 Q1 across the state, and we came up with the numerator, denominator, and measure, and it looks like 80% of all 911 stroke or TIA patients received a blood glucose check. And so when we looked at this, we're like, well, how can we improve this? What do we want it to improve to? And we looked at a data point of 90% of all patients we think should have blood glucose monitoring in the stroke or TIA category. Next slide. So this is what it looks like on a run chart. And we're taking a look at data points over time. We can't just take one data point in time and decide what to do with it. It's kind of like looking at one piece of film from a movie and deciding whether the movie was a good one or a bad one. And at this point in the run chart, we don't have any measures that are implemented either. But we can look at our goal, which is the red line, and we can look at the data points, which is the blue line. Next slide. So we did that. And here's the data from the state. Thank you, a huge shout out to the DI team in putting all this data together. And if you can look down there on the bottom line, the percent of EMTs that perform blood glucose monitoring for stroke and TIA patients from Q1 2020, and then it marches on to 2022. Also in there are AEMTs, CCs, and paramedics, which I think are the purple line. Only at one point in there did we reach our goal, but again, this chart doesn't show any kind of relevant interventions and going through a PDA cycle, what that might look like. Next slide. So here's all the reasons why we may not have made that mark, right? So it could be knowledge about what we need to do, engagement of personnel, and the equipment. Do we have the equipment? Do we not have the equipment? These give us the opportunities from a primary and secondary driver to make improvements in the system and look at outcomes after that. Next slide. Here's that plan, do, study, act cycle, and we have to come up with, we decided 90% was the goal. We're going to measure, we're going to implement, we're going to measure again, and we're going to continue this cycle through and through. Next slide. And so here's finally what we would expect a run chart would look like over time. The first section, the first third there is cycle one where we've measured, then we make an implementation, we measure again, we make an implementation, we measure again, and we continue down the cycle in an ongoing way. And so this is what our committee has been working on for the past year. We've got the manual, we've got a guide, and we've got a measure that's a state measure that we're looking at that also happens to be a national measure. So, as things usually go, I am passing on a voluntold to this group for a pilot beta study for February. We're going to ask every physician on SEMAC, every program agency and every SEMSCO member to try this process with your home agency. We'll give you a login. The DI team has already put together documents, templates, and we'll have written and video instructions on how to do this. It'll be nothing more than logging in and pressing a button to see the data from your agency. Come up with a run chart and then report back on this measure of blood glucose on stroke and TIA. So what do you get out of this? We're actually considering this as a gateway measure, if you would. First one's free, it's on us. And you'll be able to see the power of the data and what's happening at your agency with the press of a button. Then you can decide what you need to do with your agency in trying to improve this. And we'll move forward with other pieces. We also like to, and we really don't care about what the data shows as much as the process working. As we move forward, we are looking at about 20 other data points then to share out that you'll have a button to press and figure out what to do with that information in a run chart over time. We really want to be collaborative with this. We want to be inclusive with this. This is not just our process and data, this is everybody's process and data, and we want it to work for you. Once this process gets tweaked and we see what the other numbers are, then we can roll it out with a slew of reports, and we'll make it available for you with timeframes and even an auto delivery process, so you can get a report in your inbox every Monday for the past week or however you want to set it up. So that's my pitch. I appreciate that. We'll have everything sent out by Boardable with directions, videos, links, etc., and ask that folks really try this and get back to us so we've got a good working document moving forward from February. Thank you, Mr. Chairman, for your time. I'll take any questions if you have any.
Any questions? Anybody has?
I would just add on to that ask, this is an ask to all the council members, both SEMAC and SEMSCO, and if not directly by you, by who you feel the appropriate person is in your agency to initiate something like this. And, what this will really allow, even more than, and I don't know if you spoke on this part, we're not looking necessarily at the metric or how well your agency is doing or something else. This is really the test of the system through about 60 people and hopefully 60 agencies that are testing it for 1,700 agencies, so that we put out a good policy manual, so that we put out a product that, that people can engage with, so that we can get the feedback and tweak it on a smaller scale, and have hopefully each of you be champions, of the goal of quality metrics and moving forward on some state initiatives and understand exactly where those are coming from. And thank you to all the work that you and your committee has done, Dr. Redliner. Really just outstanding. So thank you.
Excellent. Thank you.
Thank you so much.
Would there be a penalty if we don't do this, like canceling 3 elective transports?
I think the number is under discussion at this point.
Transparency, your name will go on the website.
No, actually, you'll have to come up with more policy statements. Anybody have anything else for the committee before we close? Yes.
Josh Lynch from Buffalo. Just a quick point of information about a free resource available to EMS providers across the state for the assessment and referral for patients with substance use disorder, particularly opiate use disorder. So this is a program called the Matters Network that's available for free to EMS providers across the state. It's app-based. It doesn't include using or making any phone calls. It's a process that can be done in just a few minutes on scene. So typically, EMS providers may get frustrated by going to the same house over and over again for the same problem. And oftentimes that frustration is because we really don't have much to offer patients with opiate use disorder except for bringing them to the hospital, which oftentimes, as we all know, they don't want to do. And maybe they don't want to do that because the hospital doesn't really have much to offer them either. So that's really where kind of the premise of the Matters program was built, and really what that is a free app, Matters Network. You can search it in the Google Play Store or on the Apple Store. Basically what that allows you to do is to enter some information in about the patient, and the patient will see a map of treatment organizations that can accept them. So we've built relationships with about 200 treatment organizations around the state and have solidified about 1,800 weekly treatment slots for patients. So they typically get their first choice appointment, usually the next day. That turns the tone of the interaction with a patient that's just overdosed, has gotten naloxone, is in withdrawal, and is frustrated because there's really no options for them, into an interaction where hopefully the EMS provider and the patient both leave a little bit better off with an appointment really happening the next day. So there's a few other resources on the app, including access to naloxone, fentanyl test strips, requests that are all free that can be sent to the EMS agency. So I hope that you will find that helpful. In 2023, we will include referrals for mental health resources also. So you could refer a patient to mental health treatment right from the scene of a 911 call. I will put this information up on Boardable. There are a few handouts, just one-pagers on the program in the back with the QR code to get to the app. And then just one other piece. Dr. Daly and I have been working on an EMS initiation of buprenorphine or Suboxone program for New York State. There are a few agencies that are ready to do that. We're waiting on BNE approval for us to move forward to do that, which we think really will save lives. So thanks again. It's Matters Network is the name of the app, and we encourage you to distribute that out to the agencies in your regions. Thanks.
Okay, just ask 2 questions.
Thank you. Go ahead.
Is it limited to any particular parts of the state? I know you said you had a pretty big network, but if EMS providers were to try and use that and fill in the blank, they'd be like, okay, there's nothing here versus if you were to use it in Buffalo or Syracuse, there's a lot of options.
So if you look on the app or on the website or on the little map that's on the one pager in the back, you'll see where we are geographically distributed. We have pretty good coverage across the state, admittedly in pieces of kind of central New York and up in the North Country where resources are fairly limited. You'll see that those partners are also fairly limited, but I assure you we are working every single day on growing the network. There's also some capacity to refer someone. They can pick an ongoing tele-addictions care. So if there's not a brick and mortar place anywhere close, reasonably to where they live, they could choose to receive their care via telehealth.
Mr. Chair, if it's possible, and Dr. Concha, by the way, amazing work, and thank you. Would it be possible maybe to have a 4 or 5 slide PowerPoint or something just to see what it looks like and what that interaction would be, or presentation at the next SEMAC meeting?
Yeah, that would be excellent. Would you be able to put that together?
Yeah, absolutely. We'll keep that brief. And I wanted to throw that out there today because New Yorkers continue to die from opioid overdoses, and I thought if we can get this into the hands of EMS providers now, we can do that, but I'll have something prepared for February.
Okay, great. Thank you very much. Any other discussion items before we close? Okay, I want to thank everybody. Great discussions and thoughts on EMS overcrowding and EDs. Yes, Ryan.
Just the last thing for this committee. So our next meeting is in February, and the first week in February, which means we need all presentations, agendas, anything else for the next meeting by January 9th. And I know that, with the holidays and everything else, it's a tight time period. That's why I like to put it out here to everybody and everyone in the room who also needs to know that. January 9th, that's a Monday, close of business. Everything needs to be into Val or Teresa for the next council meeting. Thank you, sir.
Thank you. Okay, that being said, can I have a motion to close? Dr. Cooper, second. Dr. Berquist. Anybody against? Okay. I'll give you a few minutes back till the next meeting. Thank you all. Have a good holiday.
moment as soon as they get the high sign from our IT folks. Okay, we're on the record. Thank you very much this afternoon. This is the 2022 December 7th meeting of the State Emergency Medical Services Council. My name is Mark Philippi. I am chair. We all rise and face the flag, recite the Pledge of Allegiance, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. If you could please remain standing for just a moment. I'd like to ask us to observe a moment of silence in recognition of Pearl Harbor Day. Obviously, this is a significant day in our American history, and take a moment to recognize that. All right, thank you. You take your seats. All right, good afternoon. Ms. Osgood, would you please call the roll? Or Ms. Allen, sorry. I'm used to certain ways of doing things, so Ms. Allen.
Allison Burke. Stephen Cady.
Steve Cady, present.
Dr. Krupe. Mark Devers.
Mark Devers, present.
Don Duval.
Here.
Michelle Fornes.
Mickey Fornes, here.
Carl Gandolfo.
Carl Gandolfo, present.
Gregory Gill. Jason Haig.
Jason Haig, present.
Teresa Hamilton. Donald Hudson.
Hudson, present.
Dr. Isaacs.
Here.
Alfred Kim.
Here.
Steve Kroll.
Steve Kroll, present.
Andrew Knoll.
Andrew Knoll, present.
Jared Cutzon. Alan Lewis.
Al Lewis, present.
William Masterton.
William Master, present.
Michael McAvoy.
Mike McAvoy, present.
Elizabeth McGowan.
Elizabeth McGowan, present.
Mark Philippi.
Mark Philippi is present.
Marianne Portoro.
Marion Petoro, present.
Dr. Raybridge.
Raybridge, present.
Dr. Redlener.
Redlener, present.
David Simmons.
David Simmons, present.
Carla Simpson.
Carla Simpson, present.
Christopher Smith. Chad Smith.
Chad Smith, present.
Jeffrey Van Beveren.
Jeff Van Beveren, present.
David Violante.
David Violante, present.
Roll call complete.
And we have quorum, I'm assuming? Yes, okay, we have quorum, very well. Yep, always want to make sure. We have run across that in the past. So first and foremost, before I get into the formal agenda, let me welcome our new council members to the table and a number of names that some of you may have been unfamiliar with. Elizabeth McGowan from ARAMS, welcome. Dr. Douglas Isaacs from FDNY, welcome. Chad Smith from Midstate REMSCO, welcome Chad. And Alfred Kim from Westchester REMSCO, welcome to you as well. Also, Dr. Jason Winslow joins us to the SEMAC, new SEMAC representative as well. Dr. Winslow, well met, sir, and long time coming. So that being said, this is my last meeting as chair. It has been a long and winding road, and a very interesting one at that. I want to first and foremost thanks everyone for your support, and we'll get into a little bit more on that once I get into my formal report. Moving along, I have a request for a motion to approve the stenographic minutes of our September 22nd, 2022 meeting.
I'll make that vote. Al Lewis.
Al Lewis, and second by Carl Gandolfo. Any discussion? changes or modifications to the stenographer's report? All right, all in favor of approving as the minutes, signify by raising your hand. Any opposed? Any abstentions? Very well, the minutes are accepted. Thank you. I understand we have no correspondence to the council, so I'll begin with my report. First off, a couple of things that I've been working on. One of the projects that's been ongoing is the bylaws technical advisory group. We submitted our draft of the bylaws to Director Greenberg and then on to the Division of Legal Affairs for a first once over, make sure that we haven't tripped any legal landmines before we send it out to the general membership for review. The initial draft is onboardable. It has been for a bit of time, so certainly take your advantage of that if you have an opportunity. Submit some comments to myself, Dr. Langsam, Steve Kroll, or Carl Gandolfo, who are working on that project, and we'll be happy to entertain that when the time comes. But that will come back to the full council, most likely in February, I'm hoping. So we're hopeful for that. So, in addition to that, I would like to, at this point, announce that one of my final acts, in collaboration with the executive team, we're going to formulate a technical advisory group for the program agencies. Most of you know the program agencies generally serve the regional councils. However, as a part of Article 30, they are designated as a resource, and there are opportunities for some bidirectional communication and some transparency. Oftentimes, there are situations where the information that's specifically effective to the program agencies may not be known directly to this board or to the regional councils for that matter. So to increase that level of communication, we are going to create a program agency tag. The tag will be chaired by Rob McCartan, who's currently the group elected chairperson for their team, and it will continue to serve at my successor's pleasure and the pleasure of the council. So we will put a resolution to that effect on the record. I've sent that to Ms. Ozga, but that'll be one of my final official acts. The second, I'd like to bring up more for some thought, but also potential action at the February meeting, and I'd like you all to think about this as we move into 2023. One of the things that we have had a lot of discussion about at multiple meetings is the ability to communicate effectively between the elements of our state EMS political structure, whether it's the SEMSCO to the REMSCOs, whether it's the REMACs to the REMSCOs, whether it's the program agencies to the REMSCOs, to the SEMSCO, to the SEMAC. It all goes back and forth, and we're all supposed to be working and pulling in the same direction. So that being said, all 18 regions have a representative on this body. And it makes sense to me that moving forward, the regions have an opportunity to report out on two things. One, what innovative programs or projects they're working on, and two, any problems that they are finding at the regional level. So it's a couple simple asks, and what I'm asking is that each region would report out not more than 2 minutes unless something really needs further discussion and there are motions to be made. But that 25 minutes or so of our meeting, I think, is well spent to give everyone an opportunity to be heard and to make sure that the REMSCOs are, to some degree, being held accountable to their own constituencies. That the people need to know that you're here and that you're representing. So that's something I'd like you to consider moving into 2023. I've spoken with the executive team about that, and certainly have more discussion about that in February. One of the other things that I've had the opportunity to do, and I reported out on this in SEMAC, I want to specifically thank Steve Kroll and Dr. John Morley from the Department of Health, and Director Greenberg, of course, for the opportunity here. I had a chance to meet with the Public Health and Healthcare Policy Council, which is our sister council in public policy. They are the hospital version of this body for public policy and and hospital policy. So met with them briefly about the issue of hospital drop times and hospital wait times. The meeting was very positive. It looks as though we may have an opportunity to engage with them more directly. And so we're waiting to hear back as to a possible time when we can meet with the leadership of FIPIC and to have some further discussion. At SEMAC this afternoon also, where there was discussed the formulation of a work group A number of physicians and other stakeholders are going to join in that group so that we can have some discussion points. Dr. Cooper was kind enough to remind us that some years ago, along with Dan Clayton and some other members of this body, there was a task force that was working on communications and improving system capabilities between EMS and hospitals. We'd like to kind of revitalize that. So the first step was meeting with the leadership of FIPIC. Very pleased that that went well, and very hopeful that we'll be able to move forward with that. And again, I want to thank Director Greenberg for his help with that. It was instrumental in making that meeting successful. Just as a quick placeholder, I know the director will mention this later on. The EMS medical director is being worked on. That was brought up at SEMAC as well. I'll let the director speak more about that. The meeting schedule for 2023 is up. If you have not seen it, there have been papers on the desk over here. So the meetings will be here at the Hilton Garden Inn, January, May, September, and December of next year. Please see the dates that are printed, and we'll also be sending that out via Boardable. February. Did I say January? Yeah, I'm sorry. I'm thinking ahead of myself here. Yeah, thanks. So February 6th, 7th, and 8th. We're adding the 6th more or less officially because that had been the date that the program agencies had been meeting. So we're going to continue to use that as their general meeting date as well. Just briefly before I pass the baton over to Dr. McAvoy, I want to speak for just a second about some of the things that we've done as a group in the last 3 years. This has been a really challenging 3 years. That's not an understatement. I think we'd all agree that we faced a lot of very unique and very exciting opportunities. Some of the things that we have accomplished as a body and things that I'm proud of this body for having completed, or at least moved toward completion. Our Part 800 changes in both the education and training realm and in the operations realm. Those projects had been going on for many years before we all sat down at this table, and they have been moved on for the approval process. The opportunity to meet with the commissioner and to have substantive conversations with the leadership of the Department of Health. That has been very, very helpful to getting our voice heard and also to kind of prioritizing some of the things that we need to work on. New committees that we formed here that have been outstanding, and then the folks who have been involved in these groups, I applaud for the exceptional hard work that have been gone into them. The Quality Metrics Committee, the Innovations in EMS Committee, the Sustainability Technical Advisory Group, and our new Diversity, Equity, and Inclusion Technical Advisory Group are all working diligently and with very great vigor to move our programs forward. Mission statements and deliverables for the committees, that was an important task. In some cases, that is going to continue on into 2023, but most of the committees have done that, and I thank you for that. And one of the things that I think is going to bear much greater fruit moving into 2023, the joint meetings between the various trade organizations that have been taking place. I won't spoil the milk, but to tell you that these groups have come together and are having open conversations about how we move EMS together with a single voice. The 5 or 6 organizations that are represented, this is one of my stated goals when I took the chair of this council, was to see that we could bring those groups together, and I'm not responsible for it. I like to think that I had a little bit of a kick in the pants role in it, but I think the folks that are part of those groups really deserve the credit. So I thank all of you. I could start naming some names, but I know I'm going to miss somebody, and I don't want to make anybody mad, because this is getting you folks together was hard enough. So I want to thank you all for all the work that you're doing, and I appreciate that. And let's hope that that bears some tremendous fruit coming into the future, that we're able to bring forward a consistent and solidified message, solidarity, I think that's the word I was looking for. And then finally, the latest project, which I also think will bear some great fruit in the next year or so, is the revision of 0606 and the looking at our CON processes. So Mark Devers and the folks at the Systems Committee, thank you for taking that on. That is a huge project, and look forward to seeing some results from that. That's all I have for my report. Remember, for all our committee members, that committee agendas and documents are due to the Bureau by January 9th so that we can have them on the docket. I know there's been a lot of issue with getting information out prior to these meetings. Part of that is the process that we have no control over. So please try to make sure that all of your documents are up to Ms. Ozga and the committee chairs, out to your agendas by January 9th. Committee members, please log into Boardable. Make sure that you're checking Boardable on a regular basis. If you're having problems, you can contact Brian Weedman at the Bureau, or Ms. Ozga or Ms. Allen, who will be happy to help you with that. And finally, when we're talking from now, I'm going to shut my mic off for a while and let the rest of you folks talk for a while. Please identify yourself for the stenographer and turn your microphone on so that she may hear you clearly. And if you're using any odd or new acronyms, please try to spell them out first. I know that's one, like I said, Public Health and Healthcare Policy Council, and then said FIPIC for about 5 minutes. So I want to give the steno that opportunity to know what the heck we're talking about. That's all I have. Any questions for me? All right, Dr. McAvoy.
Thank you, Mark, for your service and all the things you've accomplished. I just have one item that I'd like to present, an award, actually. 6 years ago, on the 5th of June, we lost a crucial member and a well-known, well-respected member of our Training and Education Committee, Rich Beebe. And many other curricula that we use were developed by him. Many people sitting in this room call themselves BB medics, actually, from his educational candor. And the New York State Volunteer Ambulance and Rescue Association occasionally presents an award in memory of Rich Beebe, which is an exemplary educator award. And the award is given to a person who has consistently, over spanning a time period of 10 or more years, contributed to education, research, publication, and had a profound impact on EMS services on a state and a national level. And so this year, NYSVARA has asked me to present this award to a fellow member of the Training and Education Committee, Dr. Jeff Raybridge.
So I just want to say thank you. I'm incredibly humbled and grateful for this. And this being the Rich Beebe Award means so much to me because I, too, am a Beebe medic. I was in his 1988 class at Hudson Valley Community College and spent many a night in the ICU at St. Peter's with him learning how to take care of both patients and their families. And so this means a tremendous amount to me, and I'm really appreciative. Thank you so much.
That was my report.
And you caught me wiping my nose. Okay. Thank you, Dr. McAvoy, and congratulations, Dr. Raybridge. Second Vice Chair, Mr. Haig, where are you? Oh, there you are. Mr. Haig.
Right here. Nothing to report other than elections. If you'd like to proceed with those, Mr. Chair.
Yes, please do.
All right. All right. Final call for nominations for the position of chair of the SEMSCO. Last call for nominations. Any nominations from the floor? Any nominations from the floor? I declare nominations for the position of Chair of the SEMSCO closed and entertain a motion for the Secretary to cast one ballot.
Jason, can you state for the record who the ballot will be cast for?
Oh, yes, sorry. That would be important, wouldn't it?
To be determined.
The current sole nomination is Dr. McAvoy for the position of Chair of the SEMSCO, and entertaining a motion for the Secretary to cast one ballot.
I'd be glad to make a motion for the Secretary to cast one ballot for our colleague and friend and esteemed person, Mike McAvoy.
And your name, sir, making the motion?
Yes.
And no, who are you? Identify yourself.
Right. Stephen Kroll.
Thank you.
Thank you.
And Raybridge, second.
And do we have a second?
Dr. Raybridge.
Dr. Raybridge making that. All right. All those in favor signify by raising your hand. All right. Congratulations, Dr. McAvoy.
Congratulations, Mike.
All right, there's a single nomination for the position of first vice chair. That is for myself, Jason Haig. Any other nominations for the position of first vice chair? Any other nominations for the position of first vice chair? Any other nominations from the floor? I declare the nominations for the position of first vice chair closed and entertain a motion that the secretary cast one ballot for the position of first vice chair for Jason Haig.
Carl Gandolfo, and I'll make the motion.
All right, thank you, Carl. Do I have a second?
I'll second.
All right. Motion made by Carl Gandolfo, seconded by Mark Devers. All those in favor signify by raising their hand. Excellent. Motion passes. All right. And for the position of second vice chair, we have two people nominated, and that would be David Violante and Teresa Hamilton. Open any other nominations from the floor? Any other nominations from the floor for the position of second vice chair? Any other nominations from the floor for the position of second vice chair? I'll declare the nominations for the position of second vice chair closed. We will be voting by ballot for the position of second vice chair for the candidates of David Violante and Teresa Hamilton. Those ballots will be passed out and then collected.
Thank you. While the ballots are being distributed, we'll continue on with regular business and then pause for the collection of the ballots. Mr. Haig, do you have anything else for the second vice chair?
Nope.
Okay. Very well, then, while the ballots are being handed out, one moment. I am reminded that these are a matter of public record, so would you please write your name at the top legibly on each ballot so that we can mark your vote, please, and thank you. Okay, while that's being done, we'll move on with the EMS staff report. Director Greenberg.
That's me. All right. Try and go faster than last time, since I think most of you were in the room last time. In operations, anybody want to answer for me? Full service inspections are continuing. But again, just a big shout out, and actually, I just wanted, where is Craig? Craig Gill? There you go. Thank you very much. Well, I don't know if you were paying attention last time either. So we know that your area got some snow in the recent history, and I really just want to say thank you, and the amount of coordination and work that you did for many, many days with an amazing team, and to Chief Major and the entire Western team and everybody who went out to help there as well. When you talk about collaboration and synergy, the number of people who came up to me and said how this storm really just showed some of the positive things that even came out of COVID, in learning how to work together, learning how to try different things and different methods. The work you did, the team you coordinated, and the things you achieved without bringing in outside resources, and even testing us on what that would look like. I just want to say thank you for all your work, and to Chief Major and all the Western team, thank you. The work you did truly did save lives, so thank you.
Thank you, Director Greenberg. I don't say much at meetings. I like to keep it kind of quiet, but I do have to bring up the fact that my joke is the state is here and they're here to help. And we constantly joke around about that, but I have to say during this incident, it was a rapid incident, short in duration, and the assistance that we got from the state was amazing. This is not the old division of EMS. This is quite a progressive group under the leadership of our director and our deputies and everybody there. It's a completely different attitude. There was no task too small for them to take on. There was no task too large for them to take on. And the work that was done was remarkable. I can't say enough about it. The meetings, the director and the deputy director and all his staff on a conference call at 9:30 when I know some people had personal issues that were going on, but still they were there. Staffing our EOC out in the field, it was amazing. So I thank you and applaud where this division is going.
Thank you so much. All right, moving on. So full service inspections, we spoke about that. Investigations continue to be processed and are on a normal time frame. Administration-wise, again, our PA contracts, we have 8 executed program agency contracts that are executed. The rest are in the works. Feel free to follow up with your program agency if you are the representative here that works with them. There are 9 executed BREMSCO contracts, and the rest are, pending different actions along there. And just a reminder, we really want those contracts signed and completed and out there, because that's what allows us to spend the money through aid to locality and get it out to the regions, and to allow those funds to really help enhance your region. So please, by all means, anything we can do or you can do to help proceed that would be wonderful. On the education front, we continue to process applications. I think Mike will give during training and ed some updates on some numbers. We're working on some education and training for regional educational plans, and I think Mike will also talk on that one. We have heard some concerns with PSI, and so just a reminder, we test nearly 20,000 people a year, certify nearly 20,000 people a year. PSI, does a tremendous amount of work, and in that process, it's very interesting. We hear, oh, there's all these complaints, and so what we started at the Bureau and working with PSI is using what's called Zendesk, and it's basically a ticketing system. So any time that Drew or John have an issue with PSI, they start a Zendesk ticket, and then it works to get resolved. Well, the reason I bring this up is for all these issues, reality is we think the issues are pretty limited in the grand scheme of things. There's definitely areas where things can get better, but they're limited. And so we're going to start to report out on how many Zendesk tickets we enter or put in or have to be handled on a quarterly basis, just to give transparency in what we're seeing and what's out there. This is a process that when it first started, I was on the phone with PSI literally daily. So we've come a really long way. I don't speak to them too often these days, and the Zendesk process has really helped, and hopefully that transparency to each of you will help understanding too. I did get some great feedback this weekend about some pockets and some areas in the state that still need some help in testing centers, and even with the ability to test at home. And I know Drew Chesney has already sent me a map of the updated things, and so we're going to be taking a look at that and having a conversation with PSI. Hopefully by February I'll have some updates on you on what we can do to improve that. Data and informatics unit continues doing great work. We've had about 3.5 million EPCRs entered into the system in 2022. We anticipate to end up around 3.6 for the total year. We have identified recently that there are hiccups sometimes in charts coming in from agencies, and often the agencies that we've reached out to aren't aware of that hiccup. So we're going to start working on some processes in order to share some information, let people know, hey, this is how many charts that we're receiving at the state. Let them identify, wow, you're missing 10% of what my actual volume is, in order to see if there's any problems with that. And I will say it does seem to be limited to 1 or 2 EPCR platforms where that problem is coming in. In the trauma world, we're working on a Part 405 0.45, the regulatory updates for the ACS standards. There are some big changes coming in that one. We're seeing more and more trauma centers come out, so level 3 trauma centers. And STAC's next meeting is January 25th, so interesting stuff on that side. For EMS for children, we are very excited. Jacob, give a wave. So Jacob has been in our data and informatics unit for the past couple of years now, and has recently applied to fulfill the role as a pediatric data specialist. So he'll be working for HRI as part of the EMS for Children grant, and we're really excited to have him on board in that role. EMS for Children grant has been submitted. Hopefully we'll hear shortly into 2023 on the award. The EMS for Children's EMS survey is coming out in January. Please encourage your agencies to go online and complete that. It doesn't take too much time. Vital Signs was a success with about 750 attendees, both online and in person. And, for everybody, for all those communities, again, that, Val's not here at the moment, but, probably gave Val a slight heart attack, when 4 weeks out we were 200 people. It was, really exciting to see everybody and bring them together, and to have Albany be a really wonderful location for it. The memorial, like I mentioned before, and this is really important. So we spent a lot of time, myself, Carl, Terry, a number of people on a memorial committee discussing what the new memorial will look like. And in the process of discussing what the new memorial will look like, we have since put it out to bid. We worked to get responses and everything else. And when they came back, what I think our vision was wouldn't be the same. And so instead of moving forward on something that might not be the vision of what I think the committee thought it would be, it might have to go back to the drawing board now a little bit and have some modifications, which I think, in speaking to the Passionist Committee, the way that Jason Hay described how the tree and the leaves would fall is really important to all of us. And so we're going to go back to the drawing board a little bit, still in the same concept, but a little bit different. And hopefully I'll have an update for you in February. But unfortunately, due to supply chain and the way things would work, I want to make sure that truly it's perfect, and hopefully that's okay with everybody here. So, by the way, to those committee members who helped us on that council, you're being reformed again, and we'll be back meeting a couple of times, but I think we're in a good direction. So for council operations, we're moving forward, and the dates for next year are up. Those will be, they're listed out there. The OASIS grant for mental health continues on. A lot of great classes going on through Jenny and her team in getting things out there, and some really, really nice feedback. And I want to, at this point, pause and ask Chief Major to come up and give the briefing related to MULS. This is an excellent opportunity for everybody here. I know the last group was a little bit quiet, but to ask questions about MULS and also to bring up any concerns you have that we can bring back to this statewide initiative. So thank you very much, Chief Major.
Director, can you hear me? Very good. Okay, sorry. Good afternoon, everyone. My name is Ed Major. I'm the branch chief out of the Western region. Just a couple updates. I wanted to talk about the MOLST update. We have worked collaboratively with the MOLST team, the MOLST executive team. Give a lot of credit to Dr. Bamba, Excelis, Dr. Dorset, Mike McAvoy, Dr. Cushman, and an entire group of collaborators that are really committed to improving quality. The form has officially gone through the approval process. It got approved, and then what happened was there was a delay based on feedback from the OPWDD legal team related to some modifications and changes. So we have a path forward. We're waiting for approval. There was a training and education component of that. We had scheduled a MOLST update at Vital Signs that is currently available at the Vital Signs Academy. In addition to that, we're doing some scenario-based training and education once the form is officially approved. So I did say the majority of this information previously, but we do intend at the same time to roll out a policy update to 9910, which is MOLST, DNR, and frequently asked questions. So that information is forthcoming. I am one not to give a timeline based on the delays that we have unfortunately encountered, but it is an important component of what we're trying to move forward with. In addition to that, just changing subject a little bit, we had a training and education component, was an adult home and EMS sort of level setting opportunity. It was attended by over 800 individuals. It did involve most components, but the idea was based on complaints and information from both sides of the house to sort of level set what the expectations are from a regulatory standpoint, what the regs are for ACFs, what the EMS regs are, and to have collaboration so that we can have a path forward in an understanding of a common operating practice for ACFs. Based on feedback from EMS, we have a second session scheduled for December 13th from 12 to 1, and that's going to be about the different capabilities of different facilities, whether it be a nursing home, adult home, group home, and all the associated information. That was feedback from EMS. So training and education will be coming forth on both of those topics. I'm happy to answer any question and entertain. Direct, I'll just take liberty to say go Bills. As you know, they're the #1 seed, sorry. And then secondarily, I apologize. He told me to be brief. I will end it at that unless there are questions.
Mr. Chair, I do have a question.
I'm sorry, Mr. Kroll? Go ahead,
Yeah,
thank
just a
you.
quick question, Ed. First of all, go Bills. And Steve Kroll speaking. For the education on most, my agency and some of folks in my region have been running to what I consider a unique problem, and I just want to mention it as for part of the education going forward. When we see people who live in supportive housing and assisted living facilities, not skilled nursing, but the SNF, the supportive housing and assisted living, we are running into most that are locked in an office by the staff that work during the day, and we come to take patients to the hospital in the evening and night, and the night staff don't have access to those forms. And obviously, we have to work those things out at the local level, but it might be good if in the training and education, it was really specified that those need to be available 24/7, 365 to people who have given some of the control for their paperwork over to somebody else.
Steve, I agree wholeheartedly. Certainly an operational issue, but we will encompass that into the scenario-based training and education. And this is going to be an ongoing development of communication between the different divisions from the regulatory side. And I think from a local level, operationally, EMS agencies and facility leaders need to kind of coordinate those things. I think the other component is evaluating data, because we got to do some database things. One other thing, Steve, that futuristically I will say we're working on the next step after this gets rolled out. Obviously, there'll be a transition between the old form and the new form and how the implementation goes forward. But we will be rolling out eMost will be the next component of that. Now, that's certainly downstream, long-term, and we're looking at working with data informatics on some demo counties that are all on one ePCR platform to try to roll that forward on the eMost scenario. So there's a lot of wheels in motion, and I appreciate your feedback, Steve, and I'll make sure that that's taken into account. Director, anything else?
That's wonderful, unless anybody else had a question. Chief Major, thanks so much. From a regulations point of view, so the education regulations have gone through the internal. We have to go in front of a committee internally as they move forward, so it has cleared that. The operations regulations go through that same committee the week of the 19th, and thank you to Drew Chesney for helping us in progressing that. Also excited to say that there has been an offer sent out to our policy fellow, which is part of the public health fellowship program. So hopefully by February, we will have that position filled and in place and able to help do this. Don't worry, Drew, you'll still be able to participate in all the fun of regulatory reform, but there will be one person who is primarily dedicated to it. That fellow will also be working on policy reform too, so looking at some of the policies that many of you have identified and said, hey, can we get an update on this? Can we get something in writing? So on and so forth. So that will be coming forward as well. The executive orders, currently the executive order in place that affects EMS is the staffing crisis, so just keep that one. The others have since sunsetted. The Rural Health Task Force is down to the last 2 members that are waiting to be vetted, but I am excited to announce again that Ann Smith has been nominated, or actually appointed, as chair of the Rural Health EMS Task Force by the Governor's Office. So again, thank you, Ann Smith. So for everybody here, we constantly hear, hey, can I get a single piece of paper that shows me where the forms are, where the Drupal is that I need to submit, where the fill in the blank that we created last week and has a ridiculously long URL to get to. We have created that page. It will be going live on our website, most likely just about the first of the year. It does have a drop-down section to it, so depending on what forms you're looking for or what Drupal you're looking for or how to submit things, you would drop it down, say education, CME. It would give anything that is a PDF and then the way to submit it. We've really done a phenomenal job, and I thank everybody here for making this possible, of moving from literally 2 baskets of mail showing up in our office every day down to, like I said, Letitia turning and throwing couple of pieces of mail under her arm. So, an omen's job, and I really appreciate everybody here. This is also Letitia's last day with us. She's moving into another state position, and so we're excited for her. But Letitia, just thank you for all the work that you've done and answering the phones and listening to what she had to answer, and all the EMS community members she got to interact with on a daily basis. So thank you to Letitia. The state... So the state EMS medical director position is in works. My guess is we'll know a little bit more publicly about that, in the June, July period of time. That will be a state position, or most likely be a state position in a part-time capacity. So we're excited to see that one move forward. A reminder to everybody around this table, as we would like to get all the documents out to everybody here in a timely manner, including everybody on the outside tables. The next meeting is the first week in February. And in order to achieve getting the documents out in a timely manner, we need all agendas and associated stuff by January 9th, Monday, January 9th. So please, 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 Monday, January 9th, I'm sure you'll get a bunch of email reminders from Teresa, who will be collecting everything. Please have your agendas in on time so that we can expedite that process and move it forward. I know the holidays and everything are in between, but that is, super important for us to get there. And then finally, on behalf of myself and Deputy Director DeZura, I really just once again want to thank Mark for the tremendous work in really getting us through a pandemic, getting a team that had a lot of obligations to a lot of different things through a pandemic, as well as advancing a system, starting a number of amazing technical advisory groups and committees that truly, I think, will shape the way the future of EMS goes in New York State. So thank you, Mr. Chair. End of report. Happy to take any comments or questions.
All right, does anyone have anything for Director Greenberg? All right. In case you're wondering, we are going to take a bit of a pause on the election. There are a couple of questions have come up, and we're going to try and resolve that before we announce the results of the election. So please bear with us as we work through a couple of minor technical glitches there. Moving on with our reports, the SEMAC report, Dr. Doynow.
Thank you, Mr. Chair. Let me turn it over to Dr. Marshall, as he has the second of motions.
Thank you. Good afternoon, everybody. Medical standards and SEMAC met earlier today, and we have 2 motions that were approved that are coming forward as seconded motions for the committee's consideration. The first one is New York City protocol changes, which is the addition of tetracaine eye drops to the eye injury protocol. In New York City, tetracaine is in the burn protocol, and in the collaborative protocols, tetracaine is in the eye injury protocol. So that comes forward as seconded motion from SEMAC.
There you go. It's the seconded motion from the CMAC. Do we have any discussion on the motion? All right, seeing none, I believe we need a roll call vote on this as a protocol change. So, Ms. Allen?
Is it possible to batch these two protocol
I think
changes
that's,
together?
I think that's wholly reasonable, particularly since there's no discussion on this matter. So, Dr. Marsh, you want to go ahead and move the second one?
Absolutely. So the second the seconded motion that comes forward is alignment of the New York State BLS protocols and the collaborative BLS protocols. There was a document that was sent out to everybody in Boardable which listed the differences between the state BLS protocols and the collaborative BLS protocols, and those were accepted in total, and most of those were not medication or medical related, and that comes forward as a seconded motion from CMAC.
Any discussion on this? If not, I think we can go with a roll call vote on both.
Steve Cady,
Steve Katie, yes.
Dr. Krupe,
Bob Krupe, yes.
Mark Devers,
Mark Evers, yes.
Don Duval,
Duval, yes.
Mickey Fornes,
Mickey Fornes, yes.
Carl Gandolfo,
Paul Gandolfo, yes.
Gregory Gill, Jason Haig,
Jason Haig, yes.
Teresa Hamilton,
Teresa Hamilton, yes.
Donald Hudson,
Donald Hudson, yes.
Dr. Isaacs,
Doug Isaacs, yes.
Al Kim,
Al Kim, yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Alan Lewis,
Al Lewis, yes.
William Masterton,
Sorry, William Masterton, yes.
Mike McAvoy,
McAvoy, yes.
Elizabeth McGowan,
Elizabeth McGowan, yes.
Mark Philippi,
Mark Philippi, yes.
Marianne Portoro,
Marianne Petoro, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Redlener,
Redlener, yes.
David Simmons,
David Simmons, yes.
Carla Simpson,
Carla Simpson, yes.
Christopher Smith,
Christopher Smith, yes.
Chad Smith,
Chad Smith, yes.
Jeffrey Beveren,
Jeff Van Beveren, yes.
and David Violante.
David Violante, yes.
Motion passes.
Thank you. Do you have anything more controversial for us, Doctor?
Always.
Okay.
As a result of the second motion on the BLS statewide protocols and the collaborative and the unified, we are putting a group together to look at those three documents. The discussion is that, when a BLS provider needs to look somewhere for information, where should they look? And it shouldn't matter. That was the reason. That was the discussion. Whatever document they look at, it should be the same from a BLS perspective. So we're going to try to coordinate those three documents, understanding that over the years, BLS protocols have changed due to, regional requirements and operational issues that have arisen. So that group will be put together. We already have volunteers, so if anybody on this council would like to volunteer as well, please let me know. We also discussed protocol approval update process, which is going to be simplified and brought back to the next meeting. There was some data requests on pediatric patients, which we'll also bring to the next meeting. And there was two areas. One was length-based pediatric resuscitation tape and conflict with the protocol. So there's one region that noted discrepancy or difference between the medication recommended by the pediatric length-based resuscitation tape and the regional protocols. So that has been referred to EMSC. As well, there was a long discussion on pediatric CPAP, pediatric high-flow nasal cannula, especially in light of the viral respiratory surge that we are all seeing at this point, and that will also be evaluated by EMSC. The last discussion had to do with defibrillation strategies for refractory VFib and the article that's on Boardable that came out last month. So if you haven't had a chance to read it, please do so. And at the next meeting, we will have some further discussion on that. And that is it for medical standards and my part of SEMAC. Okay.
Good. Yep. Thank you, Dr. Marshall. Dr. Doino?
Mark, you mentioned a whole bunch about what we already talked about on CMAC, but we'll go through a few more things. As was reported, Jason Winslow and Doug Isaac are new members. Congratulations in joining us. Dr. McAvoy is putting together a CMAC advisory in regard to agencies using different medical devices. He'll bring that back to CMAC next meeting. It was very nice of him to volunteer to do that. There was a long discussion on EMS wait times and what we can all do to try and improve that. Mark Philippi is chairing a group of EMS providers and physicians, along with Dr. Marley from the Department of Health, to see what we can do to improve our EMS wait times. Let's see, Dr. Cooper gave his update on the MSC. Jenny from DOH talked about mental health issues. I don't know, Ryan, do you want her to give that talk again? So Jenny, I don't know if you want to come up and tell this group what you said.
It's so cool because I got to rehearse this already. Thank you all for being here. Thank you for everyone who has supported this so far. I spoke last meeting about a student who reached out and thanked the state for the support and for actually, giving them the impression that we care about them and their mental health. And support is massive when it comes to resilience. So just making these things available to our providers helps to increase their resilience. There are some areas of the state I have not yet gotten to come instruct in yet. So if you are from Central New York or the North Country and you have an agency, I would love to come bring our training in-house to those agencies. It is fully funded from a grant from OASIS. Amy has been instrumental in getting us posters. Ryan likes to hold them up so that you can see them. If you need to get a hold of me, you can email Ryan and he'll forward it to me. Or you can reach out directly to me, Jennifer.Salomon, S-A-L-O-M-O-N, like the fish, salmon, but with an extra O in the very middle, at health.ny.gov. I will be very happy to set up whatever works with that agency you're affiliated with. We've split it up into 2 parts. I'm happy to do that. Whatever works for our providers and has them feeling supported, I am here for. I think those are all the things I said last meeting. Perfect. Thank you all so much.
Good job. Thank you, Jenny. There's also some discussion on the Matters app. I would see Dr. Daly about that if anybody's interested. And that basically is the end of my report. That won't be covered in other committee meetings. And also, thank you so much for working with me over the years.
Thank you. Thank you, Dr. Doino. Anything for Dr. Doino, Dr. Marshall, CMAC, and Med Standards? All right. Hearing nothing, moving along with the agenda. That brings us to education and training. Dr. McAvoy.
Okay, education and training had a long meeting yesterday. We almost ran into safety's time, which would have been dangerous. Some staff report items, 2202, which is the EMS instructor certification policy, will be coming out with some revisions. And I think Ryan, I'm going to skip over things that Ryan already mentioned that are part of this report in the interest of time. The AEMT exam was reviewed, and there were no questions found on the exam related to endotracheal intubation, so that exam is ready to continue as it has been. The PSE for the BLS, the EMT practical skills exam, is in the process of being revised, as you know, And the manual for that will probably have another draft ready around February. They have done one run-through at SUNY Cobleskill with an EMT class and learned a number of lessons from that. They have an additional run-through or two planned in Suffolk to kind of test how the exam is going. The big lesson that came out of this is that because we're shifting from testing skills to testing critical thinking in scenario-based situations, the whole process of how students are taught to take that exam and how the instructors are taught to administer that exam is going to result in us not being able to roll this thing out overnight. So rather than seeing it in January, as we previously had hoped you might, it will probably be more like 2024 before that's ready to be done. And it will have to include some significant education for our educators on the whole process. So more to come on that, and once we finish working with the draft manual, we'll let people know about that and put it up on Portable. There was some discussion about course funding, and we're waiting at this point for some information from the Finance Committee. They have 44 responses from course sponsors giving information about the actual costs that they incur to run the courses, and we hope to use that to potentially make some adjustments to the reimbursement to course sponsors. There some data for people who are data geeks. For 2022, we had 12,000 students come through our classes in New York State. There were 60 CFR classes that produced 1,000 CFRs, 600 EMT courses that resulted in 9,000 EMTs, 30 AEMT courses that produced 300 AEMTs, and 66 paramedic courses that produced 800 paramedics. So 12,000 altogether. It's a pretty significant amount of work being done by our course sponsors across the state. There was some discussion about the certified instructor update at the last meeting, not this one, where Gene Taylor had suggested that perhaps certified instructor updates, the CME for instructors, could be done by any course sponsor rather than just specialty course sponsors, which is how that has worked until present. Gene promptly retired rather than wait for that to be decided on. We took up that discussion yesterday, and the general consensus was that that should stay with specialty course sponsors for a number of reasons. However, there was some considerable discussion about the whole process and the requirement for continuing ed for our instructors. And to that end, we're going to set up a work group to look at the requirements for continuing education for our EMS instructors, CICs, Certified Instructor Coordinators, and CLIs, the Certified Lab Instructors. So more on that as that comes. A couple meetings ago, Training and Ed made a referral to SEMAC on use of medical devices, and as you heard, I was tasked with drafting a policy for SEMAC, and so we'll work with some Training and Ed folks to put together what hopefully will be SEMAC advisory on use of medical devices by providers. And our sense has always been, as that repeatedly comes here, comes to SEMAC, and comes to Training and Ed, that decision is more of a local decision, and probably the medical director of the service, although the REMACs may have some role in that whole process, so to be continued. Ryan talked a little bit about the PSI testing. We did learn some things about PSI testing problems across the state, and that is going out for another bid, and so some of those things will be incorporated in the future with the testing contract, whatever vendor actually gets it. And one of the things that is being rolled out now is group scheduling, so that a instructor could schedule an entire class with PSI, not to test all at once, but to get everybody a testing spot. There's a great deal of frustration with the amount of time that students often wait to take the exam, because that delays the payment to the course sponsor, who gets paid when they pass the exam. And the longer they wait to take it, which they currently have a year to do so, the longer it takes to get the sponsor paid, but also the less likely that the student's going to pass when they wait that length of time. Brian talked about the Zendesk, and I did mention at SEMAC, and I'll mention it again here, if people have problems with the PSI exam registration process, they should email the Bureau rather than talking to PSI. It's very frustrating to try to deal with them. I believe we have had some suicides from people dealing with PSI. No, not really. But here's an email, ems.testingissues@health.ny.gov. And that goes to the Bureau. My experience with that as a course sponsor has been they get an answer usually within half a day from emailing that. And the Bureau is much better prepared to deal with some of those issues than trying to navigate the PSI network in order to get those resolved. We have had an issue, which you're all aware of, when Division of Legal Affairs told us that we can't geographically restrict course sponsors, which now allows course sponsors to run their courses virtually anywhere in New York State. To that end, we're trying to standardize some sort of training plan that would be prepared by the regions to advise the Bureau as to what courses should and should not be approved in each region. And that had been done many moons ago as part of the Finance Committee's annual template that they sent out to each of the regions. It wasn't very effective, but we did review that template yesterday, and it essentially asks for retrospective data on who was trained in the previous year and prospective data for the next 2 years as to who would need training. We're going to continue to work on something that would be a little bit easier and would assist the Bureau in actually approving courses based on what the needs are projected to be in a region. And that may help to some degree with an issue that occurs now where 2 courses are being run simultaneously in the same place with maybe 2 people in one course and 30 people in another course. As well as cancellation of courses that occurs when there's too many courses being run in any one particular place. So if anyone has any rocket science ideas on how we might effectively do that, let somebody on the Training and Ed Committee know. That's a project that we'll be working on for a while, I imagine. The other thing that came from EMS for Children, and I think you heard Dr. Cooper talk about this if you are at SEMAC, is there is an educational program being developed for the rollout of the behavioral protocol to deal with children, and EMS for Children is looking for folks who might want to help with the educational component of the rollout for behavioral emergencies involving children. So if anyone has an interest in that, let myself or Amy Eisenhower know so that we can get you involved in that. And unless there are any questions or comments, I think that is all that I have from the Education and Training Committee. Mr. Chair.
Just one comment on Training and Ed. I would like to thank, and I apologize for not doing the last one, but the BLS PSC has really been, I'm really excited about the change in the way that we'll be testing and more practical. And so John McMillan and everybody on the education, Drew and everyone on the education team, as well as thanking SUNY Cobleskill for hosting that BLS PSC, and all the instructors as well as the students that went through an experience that we were all learning from, as well as Megan Williams for coming up from downstate just to watch it and experience it. So I think it's that collaboration and that type of work that's just truly amazing and going to help us even from the Bureau side. Recognizing it's going to be 2024 when we roll this out, because we want to make sure to give all the course sponsors that time period and that time to change the way they teach, because there's no question that these students will have to experience a different way of a different teaching style in order to be best prepared for that type of an assessment, and hopefully that will prepare them even further for the field. So thank you, SUNY Cobleskill, Megan, and everyone for all your help with that.
All right. Thank you, Director. Thank you, Dr. McAvoy. Anyone have anything for Dr. McAvoy or education and training? All right, Mr. Haig, we had an issue with the election, so apparently we have a tie. There are 28 seated members of council in the room, and we had equal votes for both. So, according to Robert's Rules of Order, we are going to revote the election. So Ms. Hosga and Ms. Allen are going to hand out the ballots. We need to revote, and we'll recollect them, and they and Mr. Devers will go back and count again. So,
Can we just do even and odd months, Mr. Chairman?
I'm sorry, too many people talking at once. Mr. Violanti?
Can we just do even and odd months? Alternate them, maybe?
I wouldn't be opposed to that, but...
Split the workload?
Split it, yeah, second and third vice chair.
Do they need to give a...
Could be. All right, let's move along while that's going on. We'll get to finance. Mr. Kroll.
Thank you very much. The Finance Committee will have one seconded motion that we'll bring up in a moment. The Finance Committee spent the last couple meetings on working through the budget request for EMS, and we work on the budget request for three things. First of all, education, of course, reimbursement. Second of all, regional councils, and third of all, program agencies. That was the main topic of discussion at our meeting yesterday, where we finalized our budget request for the state fiscal year that begins on April 1st, 2023 and runs until March 30th, 2024. That conversation was centered on really two things, and the narrative that we'll be submitting is centered on two things. Number one is we are in a workforce crisis, and there is a tremendous shortage of EMS providers. And so if you think about some of the data today, Ryan and Mike talked about how many providers we have been educating. And Mike talked about planning for how many providers we should or can educate and how to sort of fine-tune, making sure we have the right courses in the right places. At the Finance Committee, the approach we're taking is the world's on fire, and we need thousands and thousands more EMS providers in New York State, whether they are career, whether they're volunteer, whether they do both. We just need lots of them, and we need them to be working. So we believe there needs to be a sustained commitment financially of the state to doing that training. So we are proposing a 50% increase in the training funds, and as the Bureau Director suggested, putting together some ideas about how to do that. Don't just say, give us more money. So we know that there are about 70,000 certified providers in our state, down from 80,000 just a couple years ago, just 2 years ago. Ryan gave us those numbers. We see the numbers going down, yet we produce Ryan said we produce about 500 new paramedics a year in New York State. So I know he said there were 800 certifications, but 500 new paramedics isn't going to get us back to where we need to be. So we think of this as a public health emergency. We need to get back to 80,000 and then maybe get to 90,000, because at 80,000 2 years ago, our data showed that we were in a shortage situation. So for us to go from 70,000 to 90,000 means a lot of EMT training, a lot of paramedic training. So the ideas that we're recommending are things like scheduling more of free EMT classes where they're made available tuition free so we can get more people engaged, and more support for AEMT classes, considering state support for paramedic training so that the tuition is defrayed for people that want to be paramedics. We talked about a Paramedics Across New York program that would provide tuition reimbursement for becoming a paramedic if you agree to work and serve in New York, like the Doctors Across New York program. We talked about the need for classroom space that is fully equipped to teach these classes if we're going to have more classes. We talked about distance learning and how in rural areas you should not have to drive very far to become a paramedic. So we came up with lots of ideas that are all going to go into this narrative and report that will be submitted probably next week if the SEMSCO today approves the amount of money that we want to recommend for going forward in the budget process to say that's, we want to increase the training budget. And I don't know, Val, if Val and Teresa aren't here at the moment, but they can put up the motion where the budget's about $6.3 million for training in this current fiscal year, and we want to increase it 50% up to $10 million. So $10 million. I've got to pull up the exact amount since the motion's not up. Hang on. It's never where you need it when you want it. The exact number is 10.2 million. So that's the first thing we'll be bringing forward in that motion. The second thing we'll be bringing forward is looking at how to help our program agencies. And this was the discussion, the subject of the longest discussion at the last meeting, which is program agency funding hasn't changed since 1997, but the deliverables of the program agencies have changed dramatically. And some of our program agency leaders who were at the meeting yesterday did give us examples of just how difficult it is for them. For example, all the new things they've inherited as responsibilities, whether they've been in the written deliverables from DOH or just in practical survival. During the last several years, the program agencies supporting the regional MS councils helped them through COVID. The Advent ePCR, the job of the program agency at one time on PCRs was handing out big stacks of paper that were in plastic wrap to the EMS agencies, and then somebody was being paid to go through and do QI. You'd take a red pen and circle like, oh, they didn't put vital signs in. We have to, this one flunks our QI test. Now we're dealing with sophisticated ePCR data submissions and sophisticated quality issues. It requires people that have technology experience. One of the program agency leaders said the last time they increased our funding, the minimum wage was $4.25 in New York State. It's about to go to $14.20. I've basically had to cut back on the quality of my size of the things. I've had to have less people because I've got to pay people living wages. So the program agencies have the same workforce wage challenges. So we did a 50%, we did a significant increase for the program agency funding, and that would be up to $3.8 million. I'm sorry, from 3.8 up to $5 million. So we'll have a total budget request that now you see up there is $14.5 million. That will go forward if it's approved today by the SEMSCO. And Ryan has asked us to immediately continue working on this at the February and April meetings so we can submit for the 2024-25 budget by the September meeting, so a little bit earlier in the year because that's when the state starts working on this. We have committed as a finance committee to meeting with the program agencies in February, and first of all, making this a major topic of discussion at our February meeting, but we've also offered to go to the program agency meeting that occurs the day before the committee meetings and to make a real focus on showing the justification to the state of why they need a significant increase in their budget as opposed to being basically level funded for more than 2 decades. So that's the major initiative that's going on in our place. I can't emphasize enough just how bad we see the workforce situation being. And so we are looking for a really big increase in the amount of money the state spends on training. So we could all go out, and that would be through the initiatives of the Training and Education Committee and through the initiatives that will float down to our REMSCOs. We need to go out into our communities and find that tens of thousands of people that want to be EMS professionals. So we've also put in there a recruitment and recruitment fund. There should be a recruitment campaign. Ryan led a recruitment campaign a couple years ago, and I keep forgetting the name, but there was, his team went around the state with a camera crew and taped people that are EMS providers, talk about why they want to be an EMS provider. That was great. We need to go way beyond that. I mean, we are falling behind so far, so fast. We need to, I feel like it's an emergency situation where we need to find ways to recruit more, just find people to bring them into our profession. So that's what we've done. This is our seconded motion. We are, as Mike already mentioned, we're working on educational cost survey, and that data is going to be now be analyzed, and that'll be forwarded over to the Education Training Committee. But for today, we'd like approval of these budget levels for us to submit the budget request to the Department of Health, which forwarded on to the Governor's Budget Office for consideration.
Hey, Mr. Kroll, could you just verify that the numbers on the screen comport with what you have in writing? Because you said something verbally that was a little different from what's on the screen. And I just wanna make sure.
How could I make that mistake? 10,200, 500,000, 5 million, add up to 15,700. Anybody want to do the quick math? Let's see.
Is that 10,000
No,
or
I think
10
it's
million?
10 million.
Oh, yeah, let's try that. 10.2 million, 0.5 million, and 5 million adds up to 15.7, which is the correct amount. Thank you for checking me.
Nope, and thanks, Dr. Winslow, for picking that up as well. Okay, so we have the seconded motion coming forth from the Finance Committee to approve the proposed budget for forwarding to the Department of Health and the Commissioner. Have any discussion on the matter?
Steve, just a quick question. Of those 70,000, how many are actually active providing care?
Roughly 50% of them appear on a PCR. So but one of the ways to think about this is a rising tide raises all ships, right? I mean, I think there are plenty of people that take EMT classes that maybe, I know at my agency, I have lots of people that become EMTs because they want to go on to nursing school and go on to medical school, and maybe they're only an EMT for a couple of years and then they go on and do something else. Well, we got a nursing shortage and we have a primary care physician shortage, so we need to bring people into healthcare professions. I would love for all of them to stay with me forever, or go on and volunteer once they're working as an ER nurse, also volunteer. But I don't think we're in a position where we can go, we're only going to train people that we know are staying with us for a career. We just need, the whole healthcare profession needs an infusion of people, and EMS is a starting place, and hopefully a lot of them stay, but we're also feeding the whole healthcare industry.
Okay, any further discussion?
Question for Mr. Kroll.
Sorry, Mr. Lewis.
So, Steve, is it my understanding there's money in there for public service announcements or something to attract people to these programs, or what can you share with us?
So we have recommended a 50% increase in the amount of money the Department of Health spends, and we've recommended some ways in which they spend them. Okay. We have not recommended specifically what amount of money gets spent on each. So the way, and this was really the challenge given to us by the director, don't just tell us you need twice the money, because everybody wants twice the money. Tell us what you'll do if we give you more money. So we put in there and I'll be glad to share the language with you. Here is basically 5 or 6 categories of ideas that we would like you to use that money for. Now, so we're hoping they go, wow, these folks have really good ideas about solving the workforce challenges or mitigating the workforce challenges. Let's give them some more money. Then I think it comes back to us. If Ryan gets a budget for 24-25 or 23-24 that is bigger, then we have to help him and the Bureau spend it, essentially. Or, the governor's office, when they do the budget, they may sort of keyhole money into different things. I would love a multi-million-dollar sustained campaign for more EMTs and paramedics. On the other hand, I would like a multi-million-dollar infusion in money in making paramedic easier for people to attain. Ultimately, you first got to find multi-million dollars. If someone says it's worth multi-million dollars, then we can sort of decide how much goes to each one, and or someone will frankly decide for us. But first, let's try and get the money, I guess.
Thank you, sir.
Just a quick question on the co-sponsor survey. Are we going to get some numbers eventually? Because I think the survey that went out, those that didn't respond from the co-sponsors don't seek reimbursement.
Right.
So they're never going to respond on that. The second question is the fee schedule that we get now. Is that included when you put in that? Because that just increasing the fee schedule will probably eat up a lot of that money. We're getting 900 and whatever now. That has been raised in 25 years.
Oh, that's absolutely in there. That was sort of the first bullet where we started. As far as the core sponsor survey, The Bureau has closed out accepting data, and they got 44 responses out of 200-something course sponsors. Not the best, not the worst. The analysis is about to begin. The other thing that Ryan let me know is the 22 paramedic programs came forward to him and said, the way you're collecting this data, not really relevant as relevant to paramedic training. So they basically made the request to Ryan, can we assemble cost data for you in a little bit of different way? And Ryan said, please go ahead. So I don't know if you want to talk about that a little bit, but we anticipate paramedic programs will score it a little differently. But from the ones that submitted, what we want to do, Mike, when we started this, Mike gave me the work his committee did 20 years ago. Yet he looks so young. But that committee did work on what it costs to train an EMT in New York State, and basically said, we're not paying enough, and the rate hasn't changed. So it's been really easy for us to say, look at the research Mike did and trend that forward by the consumer price index by 20 years, and now we're really underwater. But we're hoping to use the data that the EMT course providers and AEMT course providers have given us to show, look, it costs us, 13, 14, 15, whatever it is, $100, and the reimbursement's still $700. But, one of the other bullets says in there, don't even worry about that. Just, you should pay for all EMT training for everybody, right? Let's continue doing these academy-style classes, not in 5 weeks, maybe in 9 or 12 weeks, where Ryan was able to get courses going that got 500 people, 250 civilians certified this year. Can we do 2,000 next year, where it's not a question of filing for $700 in reimbursement, but it is the state has a contract with you, and whatever students you get, you'll get paid your cost or whatever the right amount is to do the class.
So just quickly on the paramedic front, and you asked about that. Again, thank you to paramedic directors and Megan Williams for coordinating, actually having a meeting with them last night. Education and training spent about 2 hours with a large majority of the paramedic program directors talking about a number of different topics, and we are excited that we are going to continue those meetings going forward, probably about 8 times a year. So, and just in the report, it was quickly determined that the way that we put together the BLS report, it's a little bit different on the paramedic side of things. So that group is going to work on getting us some information on their side related to what it costs for a PSE, what it costs for, the course, what's being charged around the state. So we have some situational awareness of different paramedic programs and what they're charging, so on and so forth. So in the February meeting, we should have more information on that one, and very much appreciate everybody coming together. Interestingly enough, and I don't know, and I'll turn this one to Megan, we want to make sure too, as I look around the room and I look at Carl, that we have FDNY there, because I'm not sure that we did, and it might have just been that you weren't available or things like that, but definitely want to make sure as you're training, a good 150 to 200 paramedics a year, understanding under a little bit of a different model, but I think the feedback and the input is still very much valuable.
I'd be more than happy to serve. If you're volunteering me, then no problem. I just seem to be put on all these committees, so I figure let me take the horse by the reins here.
All right.
Just a quick question.
Dr. Redlener?
It's Michael Redlener. I apologize if this is a basic question. You mentioned the program agencies, you mentioned the training, but you didn't mention the REMSCOs. I just was wondering about the number there.
The REMSCOs have been at 450,000 for 20 years, since 97. We put in a 10% increase up to 500,000. And we focused this year mostly on the program agencies that support the REMSCOs, because they are the place where there's a lot of staff effort. But starting in January, we begin the next budget cycle, and if there's a shortfall in what the REMSCOs are being allocated, we certainly can look at that as was 10% not enough, then we can look at other numbers as well.
One thing I'll say on the REMSCOs, Dr. Rich, is Redlander, is most of our REMSCOs don't spend the $25,000 a year that they get. So we're as we talk about an increase in opportunities and things like that, all for it if we feel like it's going to get spent. What we don't want to do is increase something and not spend it. I know that sounds like a crazy thing to say, but and that's where we're at. And many of our REMSCOs do not. Our program agencies, excellent job spending. Our REMSCOs, So. And stenographer, I'm not sure how you exactly document that, but I'm going to be reading how to.
Thanks for the feedback.
Al Kim from Westchester.
Mr.
Quick
Kim?
question. On the budget lines, are there defined deliverables for asking for increased financing?
I just went through all the deliverables. That was the deliverables. But the deliverables are not assigned a specific amount of money. The state budget assigns, that's what you will see in the state budget, 3 lines. What we provided are providing to the department is the justification for those 3 lines.
But let's say you had a number of, aggregate EMTs on PCRs or number of EMTs, numbers or paramedics. Is there a number that, you're expected or we're expected to see an increase by?
Well, the document says that there's 70,000, down from 80,000, and our goal over a multi-year strategy is to arrive back at 90,000, or I'll get up to 90,000, and here are the steps. Is that 90,000 data supported? We don't really know. We don't know what the right number is. We know that 80,000 wasn't enough, and now we have 70,000. So we've tried to do as much evidence-based and policy-based demonstration of why there is a need. And if you were here at the SEMAC meeting, right, we talked all about, shortages of everybody. But if you read the full document, there's 8 pages of text behind these 3 numbers that have been developed by the committee over a several meeting period that basically goes forward with the numbers and says, this is why we think you should invest this amount of money.
And in support of that, understanding too that a lot of the bullet points that are in that current budget document mirror those that have come out of the sustainability tag, the legislative tag, the legislative committee, systems committee. So this is all pushing toward the same messaging that we've been pushing over the last probably 2 years. To get to a point now where we've got some teeth behind this, I think is a lot more sustainable, use that term, than we had in the past, which has generally been, we do this and we do a good job at it, but we really like some more money. This is a lot more defensible, in my opinion, and we're going to grow that over the next year for the next iteration. I don't mean to curtail discussion because I think this is great discussion. I do want to remind the members we do have Finance Committee meetings where you're all welcome to attend and participate. And the document is shared on Boardable. Thank you, Director, for reminding me. But unless there's any substantive disagreement, I'd like to call the question so we can move forward with the agenda. All right, all in favor of the proposed budget as brought forward by Finance, signify by raising your hand.
This is a statutory obligation.
You're right. Thank you, Dr. McAvoy. This is a statutory matter. Sorry, my bad. I'm so quick to get moving ahead here, and I got ahead of myself. It's been one of those days. All right, Miss Allen, would you call the roll, please?
Steve Cady.
Steve Cady, yes.
Dr. Krupe.
Krupe, yes.
Mark Devers.
Mark Devers, yes.
Don Duval.
Duval, yes.
Mickey Fornes.
Mickey Fornes, yes.
Carl Gandolfo.
Carl Gandolfo, yes.
Gregory Gill. Jason Haig.
Jason Haig, yes.
Teresa Hamilton.
Teresa Hamilton, yes.
Don Hudson.
Don Hudson, yes.
Dr. Isaacs.
Doug Isaacs, yes.
Al Kim.
Al Kim, yes.
Steve Kroll.
Steve Kroll, yes.
Andrew Knoll.
Andrew Knoll, yes.
Al Lewis.
Al Lewis is yes.
William Masterton.
William Michael Maston, yes.
Mike McAvoy.
McAvoy, yes.
Elizabeth McGowan.
Elizabeth McGowan, yes.
Mark Philippi.
Mark Philippi, yes.
Marianne Portoro.
Marianne Portoro, yes.
Dr. Raybridge.
Raybridge, yes.
Dr. Redlener.
Redlener, yes.
David Simmons.
David Simmons, yes.
Carla Simpson.
Carla Simpson, yes.
Christopher Smith.
Christopher Smith, yes.
Chad Smith.
Chad Smith, yes.
Jeffrey Van Beveren.
Jeff Van Beveren, yes.
And David Violante.
David Violante, yes.
Motion passes.
Okay, very well, thank you. Mr. Kroll, anything further for finance? All right, very well. Thank you for your time, and thanks for the efforts of the committee to bring this forward. It's nice to get back on track with this and meet our statutory obligations, so I do appreciate all the work you and the team did. Moving on to our previous bit of business that was held. Mr. Haig, do we have a result?
I do, Mr. Chair, thank you. For the position of second vice chair, our new second vice chair is David Violante. Congratulations, David.
All right, thank you very much, and thank you everyone for your patience and working through this. Thanks, Ms. Hamilton, for your efforts, and appreciate that. And Mr. Violante, welcome to the executive staff. Thank you. All right, now with our committee reports to EMS Systems, Mr. Devers.
All right, so Systems Committee has 4 seconded motions, so this is going to be an awesome time. Before we, I've got to get back to, due to the previous issue, I lost the place in the bylaws that I'm supposed to read. All right, Section 4 of the SEMSCO bylaws state that any member of the State Council who has an apparent conflict of interest in any matter before the State Council shall declare the nature and extent of his or her interest prior to discussion of the matter. And no such member, such members shall abstain from voting if so directed by the State Council. No member of the State Council may use their position on the State Council for a pecuniary benefit. Members must comply with applicable sections of Sections 73A, 74, and 75 of the Public Officers Law as amended. Any questions on that? So we do have 4 seconded CON appeal actions that we need to vote on, so get ready for some roll call voting. I don't know which one you guys have up there first. Whatever one's up there. Okay. This is seconded motion to uphold the REMSCO's decision for Bay Community's Certificate of Need appeal. And I will read the conclusion and recommendation from the ALJ on Bay Communities. REMSCO's vote to deny the appellant's expansion of territory application is supported by the record, and the REMSCO acted within the scope of policy number 0606. Recommend the denial of the appellant's expansion of territory application be affirmed by the State Emergency Management Services Council from July 29th of 2022. Just for clarification, if you vote yes, it is voting to deny the CON. Okay? So, Mr. Chair, we have a seconded motion and we need a roll call vote.
Okay. So I just want to be clear on one thing, because I know that there was some discussion back and forth on email, and Dr. Langston's not here, so I'm going to have to act in my temporary role as parliamentarian, as I did reading Roberts to help us out with the election here. So the way it is written in Article 30, we have the right to amend, modify, or reverse a regional council decision. So the current wording of this motion as presented, unfortunately, is incorrect. We need to vote to reverse the REMSCO's decision. A no vote would have the effect of affirming the REMSCO's decision. Does that make sense to everyone? So let me say that again. We have to move to reverse the REMSCO's decision because we don't want to modify it, we don't want to amend it. If you choose to say yes to that, then you are granting the CON appeal.
On the
This
question,
is a little bit backwards, and that's why it's important we understand what we're talking about here. A vote at this point, if you say yes to reversing the REMSCO's decision, you are voting against the ALJ's recommendation to affirm their decision. Does that make sense to everyone now? Mr. Hudson?
on the question, can we just check the record? I believe the seconded motion was to uphold.
You are correct. However, that motion is out of order. By statute, we can only amend, modify, or reverse. That's under Article 30.
Mr. Chair,
That makes a
amend,
little more
modify, or reverse what? The REMSCO
The REMSCO
decision?
decision, correct.
Okay, so a vote to agree with the ALJ, which is, I believe, what the Systems Committee did.
Correct.
Is a vote to reverse the REMSCO's decision or
No.
uphold the REMSCO's decision?
It would be to uphold. Again, I'm trying to be as clear as I
Yeah.
can here, okay? We, by Article 30, have the authority to reverse, modify, or amend. We do not have the authority to uphold.
So by voting no, you're saying no to the appeal, correct?
Correct.
Does that make more sense?
Okay. I'm sorry.
Mr. Gandolfo?
Paul Gandolfo, just as a point of order, can we just clarify what's written up there as the motion so that we
Yes,
can
so we
then
need to
discuss
change
it?
the motion.
Yeah.
Well, we need a new motion, unfortunately. This comes forward as a seconded motion, but the motion is out of order, so we need a new motion.
Do we first, point of order, do we first have to vote this down in order to then propose a new one?
Not if it's out of
So once
order.
it's out of order, it's stricken and we can proceed.
Yeah,
Okay,
it is not within the keepings of Article 30. We cannot vote on this matter because it's not consistent with Article 30. And I will freely admit here, in full transparency, this is my fault. Because Mr. Devers and I and Chris from DLA sat down and tried to work this out yesterday, and I was the one who made the wrong statement. So I'm trying to fix my own mistake here and stay within the bounds of Article 30 so we don't get appealed on that. Because I, for one, do not need another Article 78 under my belt.
Mr. Chair, Jason Haig, I make a motion
Haig.
to deny the appeal of Bay Communities, to deny Bay Communities' appeal.
I don't know if we can make that motion based on the criteria you just gave us. Right?
We can approve, we can deny, modify, or
Reverse, right?
amend,
Amend,
modify.
modify, or reverse. So we can't deny
Amend,
or
modify,
approve.
or reverse the REMSCO's decision. The appeal on the plate is to request us to reverse the REMSCO's decision. That's the appeal. They want us to reverse the REMSCO's decision.
I make a motion that we do not reverse the REMSCO's decision. Wait a minute. Hold on. Now I'm
Okay.
confused.
All right.
I yield the floor.
Yeah. Again, this is, let me make this very, very simple. If your intention is to uphold, then we need to vote to reverse and you vote no. If your intention is to reverse the REMSCO's decision, we vote to reverse and you vote yes. That is a simple answer. Yes. So I need a motion to reverse the REMSCO's decision so that we can move forward, please. Mr. Hudson.
I just want to clarify, and if the attorney's here, that might be helpful.
He is not.
I'm not comfortable reversing something because in my probably warped interpretation, that means overturning.
Correct. Right. Correct. So you vote against it. Right.
It's a yes or no. It's a binary. So you
if I understand it correctly, the motion can only read reverse, because that's one of our
Correct.
only options. So if you don't want to, you
Vote no.
You
You
vote
vote no.
no, but the motion must read
Correct.
reverse. So I make a motion that we reverse the Remsco's decision.
Thank you, Dr. Rader.
And I'll
Okay.
second that motion.
And seconded by, I'm sorry,
Carl
Mr.
Gandolfo.
Gandolfo. Thank you. Any discussion?
Yeah, I'd
Mr.
like.
Kroll.
Okay, I want to make sure I know what we're voting on, so, okay.
Yes, thank
So we now are going, we have a motion to reverse the Remsco's decision. The Remsco voted to grant this CON, correct?
No.
No, they voted to
They
deny
voted
the CON.
Okay.
The appeal before the council
Okay,
is to reverse the Remsco's decision.
okay, so if you vote no, we are not reversing the Remsco's decision.
Correct.
You vote yes, we are.
Correct.
And so by the conversation that was had at the Systems Committee, albeit with a motion that wasn't able to be brought here, a no vote on this motion is agreeing to the work of the Systems Committee.
Correct.
Thank you.
And to the ALJ's recommendation.
And the ALJ's recommendation. Got it.
Does everybody get it now? Any other
Congratulations.
discussion on
It's
the
a
matter?
double negative. We don't like it.
Understood. But I have Dr. Langsam sitting in the back of my head yelling at me right now. So,
Mr. Chairman,
Mr. Lewis,
thanks
order,
a lot
please.
for confusing all of us.
I apologize. I apologize.
Where is he anyway?
On my last day, it's a lame duck. Okay, so all right. Any other discussion on the motion? All right. To be clear, a yes vote overturns the Remsco and is against the ALJ's recommendation and against what the Systems Committee decided. A no vote supports the ALJ's decision, upholds the Remsco and the Systems Committee. Has everybody got it? Okay. Can I have a roll call vote?
Should that language be
so-
should that language be part of the motion, or is it sufficient that you just said it and it's part of the record?
I think it should be self-evident.
Okay.
But I hope that everyone understands, and we'll see in a moment. Because we're going to have to do this again. Okay, one more time. Okay.
Mr.
Miss-
Chair, Jason Haig, doesn't Robert's rules prevent you from making a negative vote?
I didn't make a
Again,
negative motion. I
the
made
issue
a
here
motion
is
to
a matter of
reverse.
statute.
Correct.
This is
If we're following Robert's rules, doesn't that prevent you from making a negative vote?
No.
At this point, I don't have that to hand.
Okay.
I don't think so. I think you're voting on the motion, which was to reverse.
Correct.
So you either vote yes or no. It's not.
Correct.
Correct.
All right. Are you ready? Ms. Allen, please call the roll before I get upset.
Stephen Katie.
Just say, I don't know.
He has to go first.
Steve Katie, no.
Dr. Krupe.
Krupe, I need to recuse myself from this one, so I'm going to abstain.
Mark Devers.
No.
Don Duval. No. Mickey Fornes.
Mickey Fornes, no.
Carl Gandolfo.
I've already seconded the motion, so it would be an affirmative vote as per Robert's rules. So yes.
Gregory Gill. Jason Haig. Gregory Gill.
Gill, no.
Jason Haig.
Jason Haig, no.
Teresa Hamilton.
Teresa Hamilton, no.
Donald Hudson.
Thank you. Hudson, abstain.
Dr. Isaacs.
Doug Isaacs, abstain.
Al Kim.
Al Kim, no.
Steve Kroll.
Steve Kroll, no.
Andrew Knoll.
Andrew Knoll, no.
Al Lewis.
Al Lewis is a no.
William Masterton.
William Maston, no.
Mike McAvoy.
McAvoy, no.
Elizabeth McGowan.
Elizabeth McGowan, no.
Mark Philippi.
Mark Philippi, no.
Marianne Portoro.
Marianne Portoro, no.
Dr. Raybridge.
No, if I can vote against my own motion. That's, all right, then I abstain.
Just as a point of order, I don't think he can abstain either. He made the motion, so the motion on the Roberts rules should count and as a affirmative vote. That's why I was saying my motion, my second is an affirmative. I've been in other situations before where I can't make a motion and then vote no against it. You can't vote against your own motion, from what I understand Robert's rules
Okay,
to be.
if that's the rule, then I vote yes.
Just for the record.
You are Dr. Langstrom's hero.
Well, on the day of all days that he's not here, right?
Dr. Redlener.
Redlener, no.
David Simmons.
David Simmons, no.
Carla Simpson.
Carla Simpson, no.
Christopher Smith.
Christopher Smith, no.
Chad Smith.
Chad Smith, no.
Jeffrey Van Beveren.
Jeff Van Beveren, no.
And David Violante.
Violante, no.
Very well, the motion is defeated, and that upholds the ALJ's recommendation and the system's rest recommendation, so the motion fails. Thank you. Mr. Devers, the next one.
So, Glen Oaks, the conclusion of Gene Carney, the ALJ, was based on the record, the appellant failed to meet its burden of showing that the New York City REMSCO erred in approving the applicant's request for a certificate of need to expand its territory. The REMSCO's decision should be sustained. So it's the same thing that a no vote actually allows them to keep their expansion of territory, and a yes vote would deny it. So vote backwards.
It's the other way. Wow.
Mr. Devers, can I, just a point of clarification on this particular matter, what was the issue at hand? Who made the appeal and what was the issue?
The Bay community, the one we just did, appealed Glen Oaks' expansion. Basically, they were expanding into a defunct area. Bay community filed an appeal when Glen Oaks got their authority granted so that it would stay the ability for them to operate in their area, while they filed for a CON to operate in that same area. The one we just voted on that was denied. So Glen Oaks, the one we're talking about now, actually had this CON expansion granted prior to Bay community, who we just dealt with.
And so what's, just so we're clear, the matter at hand here is, who is the appellant in this matter?
Bay community.
Bay community, okay.
Over like 3
And
states.
they're asking to overturn the REMSCO decision to expand Glen Oaks operating authority.
Correct. They are asking, the REMSCO voted to allow the expansion of operating authority. Bay community appealed to overturn it.
Okay. Does everybody understand? Okay. Nobody? Well, FDNY. Okay. Any discussion on the motion?
Just to also clarify on this, so the ALJ said what again?
The ALJ says that based on the record, the appellant, Bay Community, failed to meet its burden of showing that the New York City REMSCO erred in approving the applicant's request for a certificate of need to expand its territory. The REMSCO's decision should be sustained.
All right, so in the same function as before, the motion would be to reverse the REMSCO in exactly the same way as the previous motion. A no vote basically upholds the REMSCO's decision.
Which that
Mr.
was the
Katie.
recommendation from, Steve Katie, that was the recommendation from the ALJ?
In a much less complicated way, yes.
All right, again, same thing as we just did. Is everybody all set? All right, Ms. Allen?
Steve Katie.
I do apologize. I just want to, so a no vote will be in favor of the ALJ's decision, and a yes vote would be against the ALJ?
Yeah, I'm sorry, Mr. Gandolfo, you had your hand up.
Did somebody make a motion for this, or did we?
Okay, thank you. Somebody needs to make a motion. I'm sorry.
All right.
Let's
was
go
just
back
curious.
to that.
I'm not.
All right. The motion's on the screen. We need somebody to actually make the motion.
I'll make the motion to
All right.
reverse the REMSCO decision to the
Okay.
Glen Oaks Con Appeal. Carl Gandolfo.
Steve Katie will second.
Okay, Carl Gandolfo, Steve Katie. Now, any discussion? Quick before I change my mind. Miss Allen, call the roll, please.
Sure. All right, Steve Katie.
By Robert's Rules of Order, Steve Katie will vote yes.
Okay. Dr. Krupe.
I'm the medical director for Glen Oaks, so I need to recuse myself, so I abstain.
Mark Devers.
No.
Don Duval.
Duval, no.
Michelle Fornes.
Mickey Fornes, no.
Carl Gandolfo.
As per my making of the motion, yes.
Gregory Gill.
Gill, no.
Jason Haig.
Jason Haig, no.
Teresa Hamilton.
Teresa Hamilton, no.
Don Hudson.
Hudson, abstain.
Dr. Isaacs.
Doug Isaacs, no.
Al Kim.
Al Kim, no.
Steve Kroll.
Kroll, no.
Andrew Knoll.
Andrew Knoll, no.
Al Lewis.
Al Lewis is no.
William Masterton.
William Aston, no.
Mike McAvoy.
McAvoy, no.
Elizabeth McGowan.
Elizabeth McGowan, no.
Mark Philippi.
Mark Philippi, no.
Marian Portoro.
Marian Portoro, no.
Dr. Raybridge.
Raybridge, no.
Dr. Redlener.
Redlener, no.
David Simmons.
David Simmons, no.
Carla Simpson.
Carla Simpson, no.
Christopher Smith.
Christopher Smith, no.
Chad Smith.
Chad Smith, no.
Jeffrey Van Beveren.
Jeff Van Beveren, no.
And David Violante.
Violante, no.
The motion does not pass.
Okay, the motion is defeated. Thank you. All right, moving on with the next two, Mr. Devers, I believe, are similar.
We'll talk about the next two real quick, but I believe we have to vote on them separately. It's Ridgewood Volunteer Ambulance Corps and Forest Hills Volunteer Ambulance Corps. They appealed each other and then sat down on the table in November right after EDCC was done and came up with an agreement. So they made the agenda. So now that we've confused everybody, the new motion needs to read motion to amend the decision of the REMSCO. So this one is normal. Okay. So yes means we want it to happen, and no means we don't want it to happen. If that makes sense to everybody. So they came up with an agreement. We've got the signatures from all the legal garb. So the ALJ's recommendation is the SEMSCO amend the approvals by the REMSCO of the expansion of operating territories for RVAC and FHVAC per the boundary line set forth in the signed stipulation of the parties dated November 4th, 2022. So again, with these next two, yes means yes, no means no.
This is coming forward as a seconded motion. There's no reason to do anything further with this at this point. Are there any discussion on the matter? Pardon? Which one do we have first, Teresa? I can't read it. Forest Hills is first. Okay. They are identical motions for each agency. Pardon? No. So let me just put a bit of comment on this because we had kind of a robust discussion about the methods of voting previously, but on the merits, let's have one conversation about this that I think is relevant and germane. This was brought up at the systems meeting, and I think it's important to reinforce here. This is what should happen. When two organizations can't agree on boundaries and have disputes over who should cover, this is what they should do, is sit down and try and work it out like reasonable organizational people. So I applaud Forest Hills and Ridgewood, thank you. I kept wanting to say Ridgeland. Ridgewood and Forest Hills applaud your leadership and the foresight that you had to come up with this agreement. I think this is what we should hope to see in the future from all who are involved in such disputes. Mr. Duval?
Duval, since these two motions are intertwined by virtue of an agreement between the two agencies, wouldn't it be appropriate to combine the motions and vote them both on the outside chance that one or the other could be defeated accidentally?
I don't know if that's possible, but I don't also know if that's possible. So, Mr. Gandolfo?
Did they come in as separate appeals?
Yes, they
So
did,
then-
but they came in as separate appeals. However, the agreement signed November 7th by both parties was also submitted to this body, to the executive secretary, as an agreement in principle. So that was submitted to us as, this is what we're agreeing to do. We're asking that you amend the appeal.
But the problem, if I remember
Okay.
correctly from yesterday, was, and correct me if I'm wrong, they didn't come up to the table, so we couldn't make it that happen as one, opposed to having to continue.
We were hoping to get the lawyers to agree to that yesterday, and there was no representation from one of the agencies. I kind of think, to be safe, we should do them as separate motions. I know roll calls are a pain, but they are separate appeals that we couldn't conjoin yesterday.
Correct, and they still come to us as two separate seconded motions, so I think the safe bet would be to do two separate roll calls, just to,
Yeah, that's the safe
just so it
action.
doesn't get fired back.
Let's stay safe.
Fair enough.
It only takes us the extra 5 minutes to roll call. Mr. Gandolfo?
Just as a matter of clarity for the operational aspect of this, do we need to motion this? Do we need to act on this?
This is coming forward as an unchanged seconded motion from systems. So we
Okay,
don't
well,
need
so-
to make any changes to this based on our previous discussion.
Okay.
Mr. Chair, it's a seconded motion. I'll call the question.
Thank you, Mr. Hague.
Thank you.
Ms. Allen?
Okay. Steve Cady,
Steve Cady, yes.
Dr. Krupe,
Bob Krupe, just for full disclosure, I am the medical director for Ridgewood, but since there is no conflict, it's just an agreement, I believe I can vote yes, unless someone disagrees.
Because you have some interest in this, Doctor, I think the best course when I'm being advised
Okay,
is that you
then
abstain.
in that case, I will recuse myself and abstain.
Thank you.
Thank you.
Mark Devers,
Mark Devers, yes.
Don Duval,
Duval, yes.
Mickey Fornes,
Mickey Fornes, yes.
Carl Gandolfo,
Carl Gandolfo, yes.
Gregory Gill,
Gill, yes.
Jason Haig,
Jason Haig, yes.
Teresa Hamilton,
Teresa Hamilton, yes.
Don Hudson,
Hudson, abstain.
Doug Isaac,
Doug Isaacs, yes.
Al Kim,
Al Kim, yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Al Lewis,
Al Lewis, yes.
William Masterton,
William Maston, yes.
Mike McAvoy,
McAvoy, yes.
Elizabeth McGowan,
Elizabeth McGowan, yes.
Mark Philippi,
Mark Philippi, yes.
Marianne Portoro,
Marion Petoro, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Redlener,
Redlener, yes.
David Simmons,
David Simmons, yes.
Carla Simpson,
Carla Simpson, yes.
Christopher Smith,
Christopher Smith, yes.
Chad Smith,
Chad Smith, yes.
Jeffrey Van Beveren,
Jeff Van Beveren, yes.
and David Violante.
Violante, yes.
Motion passes.
Okay, thank you. And Mr. Devers, the final motion.
The final motion is for Ridgewood. It is the same thing as the one we just did with Forest Hills, where we're amending the REMSCO's decision to go with the stipulation that they created. And just like the last one, if you say yes, it actually means yes, and no means no again. And so with that, I will send it back to the chairman.
All right, any discussion on the motion coming forward and seconded? Mr. Gandolfo?
Call the question, please.
Outstanding. Ms. Allen?
Steve Cady,
Steve Katie, yes.
Dr. Krupe,
Krupe abstain.
Mark Devers,
Yes.
Don Duval,
Yes.
Mickey Fornes,
Mickey Fornes, yes.
Carl Gandolfo.
Yes. Carl Gandolfo, yes, sorry.
Gregory Gill,
Gill, yes.
Jason Haig,
Jason Haig, yes.
Teresa Hamilton,
Teresa Hamilton, yes.
Don Hudson,
Hudson, abstain.
Dr. Isaacs,
Doug Isaacs, yes.
Al Kim,
Al Kim, yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Al Lewis,
Al Lewis is yes.
William Masterton,
William Maston, yes.
Mike McAvoy,
McAvoy, yes.
Elizabeth McGowan,
Elizabeth McGowan, yes.
Mark Philippi,
Philippi, yes.
Marianne Portoro,
Marion Petoro, yes.
Dr. Raybridge,
Raybridge, yes.